Okay, I think we'll start. Good morning, everybody in Europe, and good evening, everybody in Australia, and good afternoon to those in between, and a very early good morning to those in America. Thank you for joining us. My name is Nick Beeching, and I'm co-chairing with Tom Solomon. Welcome back to the second day of this the first virtual NeuroID course. We had a fantastic time yesterday, 491 peak delegates, and it was wonderful. Lots of interaction, and we would encourage you to keep doing the same today. There are different forms of breakout, and we'll let you know what's going as things go on. So just a reminder that if you have shared your link with somebody else, the first person using that link will be let in. Everybody else will be excluded because we can only have one person using a link at one time, and only one person will get an attendance certificate at the end of the sessions. Just for this morning, we have three speakers. I just asked them to introduce themselves, starting with Laura.
Hi, I'm Laura Benjamin. I am an academic stroke neurologist at UCL and Queen Square.
And Harry? Harry?
Oh, yeah. I'm Harry Dalton. I was a consultant physician in the west of England for many years. Recently retired from the National Health Service, so I don't do any clinical work anymore. Research stuff.
Thanks. And Chris?
Hi, everyone. My name's Chris Parry. I'm a jobbing microbiologist at Alder Hey Children's Hospital in Liverpool.
Okay, well, thanks. I think we'll get straight on with the programme. So first up this morning is a cryptic case, a short case with discussion during and afterwards. Harry Dalton, and the title of his cryptic case, if you want to start showing the screen, Harry.
There we go. So here we go, Salami shoulders. We've got a case of a 58-year-old man presents with acute, progressive, severe pain in both shoulders for a 12-hour period. No past medical history. He's not taken any regular drugs, but he's a drinker, he's a smoker, and he had a flu vaccination 4 weeks prior to presentation. He works as a council gardener, and 3 days prior to presentation, he was working his brush cutter, and he shredded a rat which went everywhere, covered himself in rat entrails. He's of Dutch extraction and eats loads of salami. Examination, this man was crying in pain despite a decent doses of opiates, and a formal neurological examination of the upper limbs was not possible simply because the patient was in too much pain. This slide shows his initial investigations, and as you can see, his liver blood tests were abnormal with an ALT of 961 and a bilirubin slightly raised at 46, but he was not clinically jaundiced. In the CSF, there was a lymphocytosis with 84 lymphocytes and a raised protein at 0.93. So here's the poll question. Quite simply, what is the most likely diagnosis?
So if you could pop these in on the chat function, I'll read them out as they come in, Harry. Have you actually got a polling multiple choice afterwards or not?
I have, yes, there is one.
Okay, so leptospirosis, I'm just going to read them as they come in. Borreliosis, brachial neuritis, trichinella, that's interesting, neuralgic amyotrophy, post-vaccine neuritis, some people suggesting hepatitis E, and brachial neuritis, painful plexopathy, a fair good collection of stuff coming in there already. Cysticercosis. Right. Okay, do you want to move to your polling slide, Harry?
Yep. What's the most likely diagnosis? 1, Weil's disease. 2, alcohol-related brachial plexitis. 3, acute hepatitis E. 4, an adverse reaction to the flu vax. And 5 is Lyme disease.
Okay, we'll let this keep going a little bit longer because there's a couple of diagnoses equal heading here. Okay, I think we'll stop there, but thank you to those that have voted. Sorry for those that haven't. So take it away, Harry. Can you see that screen?
Yeah, I can. So it looks as though virus disease and acute hepatitis E are about similar, 42%. In fact, the diagnosis is acute hepatitis E. I just need to move this slide on. There we go. With neurologic amyotrophy. The rat incident is a red herring. Virus disease doesn't really present in patients with a severe shoulder pain like this. Alcohol-related plexitis, alcohol doesn't really affect the brachial plexus in this way. Flu vaccination can occasionally cause this, but the LFTs would not be off, and this is clearly not Lyme disease. So in terms of outcome, we've got it on this slide here, serologically positive and PCR positive in the serum. An early diagnosis was made and it was given ribavirin within 24 hours of admission and achieved viral clearance within 2 weeks. This patient did not do well. During the course of his illness, he developed bilateral phrenic nerve palsy, and his long-term outcome was poor. And I'm just going to show you on this video, and I hope this works well.
Can we have a look
The
at
outcome?
Would you mind just taking your shirt off, Roy?
It's good, Harry.
Can people hear the sound?
Yeah, it's good.
Done to you. Okay. Just pop your shirt there, Roy. He's got marked intercostal recession on both sides. He's got the reason for that. He's got paralysed diaphragm on both sides because of bilateral phrenic nerve involvement. And as you can see, Roy's still breathless. His phrenic nerves are still paralysed, and we're now 11 months after the infection. And he's using his accessory muscles of respiration here as well. And Roy's movement is really quite limited. Roy, can you just pop your arms as far as you can above your head? And that's as far as you can get?
And that's as far as I'm most comfortable with it. I don't really go.
You're not going to go any further?
No.
Okay, that's fine. And down again. Now, could you turn around, please, Roy? And could you do the same thing but slowly? That's it. And here you can see Roy's got waist in both shoulders and bilateral winging of the scapulae. And down, please, Roy. Thank you.
So this patient had hepatitis C associated neuralgic amyotrophy. We know hepatitis E is common in developing countries in Africa and Asia. It's caused by genotypes 1 and 2. It causes death in pregnant women. But now we also know, in the last 10 years, that hepatitis E is endemic in many developed countries. Here it's caused by genotypes 3 and 4, and it's largely a porcine zoonosis. And the key mode of spread is by infected pork meat products. I'm just going to ask you to do a little chat function now. I want you to guess how many cases, how many infections there are in England per year. So just give us a guess. Chat away quickly because I'm going to show you the next slide. You've got 10 seconds to chat me. Nick, can you talk me through how many?
Yeah, I've got 60, 25, 1,000, 2,000, 10,000. Wow. Okay, a handful. So I think it varies between 20 and 10,000. So you've got a fairly widespread.
Well, the answer is 100,000, Nick. That's an estimate. The population of England and Wales is about 50 million. But in fact, only 1,000 lab-confirmed cases a year. So what we've got is that most patients have asymptomatic infection, and it's only a small minority who get clinically apparent acute or chronic hepatitis. But there's a grey area in between. These are patients who are symptomatic and currently not diagnosed. And herein lies the hepatitis E associated neurology, because they do not present to hepatologists, they present to neurologists. Hepatitis E is not uniformly spread. It varies between and within countries. And here are some of the hotspots that we've identified in Europe, some in southern Spain, including Corsica, hotspot in southern Switzerland, a very hot spot recently identified in Poland. So it's variable in terms of incidence and prevalence. Hepatitis E and neurological injury has been described now for the first cases was about 10 years ago. There's at least 200 cases worldwide in the literature. I've stopped counting. These include neuralgic amyotrophy, Guillain-Barré syndrome, meningoencephalitis, and there's a range of other conditions as well. It can occur in both acute and chronic infection with hepatitis E. It occurs in developed and developing countries. And the most important thing to take away from this is that the neurology dominates the signs and clinical picture. These patients do not generally present with jaundice and hepatitis. They present to you guys, the neurologists. Neuralgic amyotrophy, as you'll all recall, is a condition concentrated on the brachial plexus, usually in the dominant arm, sometimes with preceding vigorous exercise or occasionally an immunization. The incidence is more common than previously thought. GP study from Holland, 1 in 1,000. Some patients have abnormal liver function tests at the start of their illness, the cause of which was previously uncertain. We tested 47 patients from Holland and England some years ago, and we found that 5 of these patients with neuralgic amyotrophy had hepatitis E. All of them had modestly elevated ALTs and normal bilirubin, and all of them had bilateral involvement of the brachial plexus. There's a rather larger study that we did in several countries in Europe. We took over 100 cases of brachial neuritis, half of whom had hepatitis E, half of whom who did not, and we looked at the outcome and clinical phenotype, and we found hepatitis E was, neuralgic amyotrophy was common in middle-aged men, as you'd expect, but the hepatitis E group more likely had bilateral involvement and involvement outside the brachial plexus, including phrenic and lumbar involvement. So it appears to be a particular clinical phenotype of hepatitis E affecting both sides of the both brachial plexi. In terms of treatment, this is there are no double-blind trials. There's been some small studies. Steroids can be given to both HIV negative and positive cases. There appears to be no difference in outcome. Ribavirin therapy is being used in a very small number of patients with variable outcome, as our case demonstrates. In southern Switzerland, intravenous immunoglobulin is being used, and this looks a promising treatment, but the numbers are small and there's no double-blind data to date. Looking at it in a different way, this is a study from France, Holland, and England. We took 464 patients presenting with acute neurological injury, non-traumatic, and we tested a lot of them for hepatitis E. And we found 11 cases who had evidence of current or recent infection. And when we come to home down and see what these cases were, top of the tree was neuralgic amyotrophy, 5 cases, 3 of whom had hepatitis E, all bilateral involvement, all PCR positive. What about the burden of the disease in a community? This is data from a Scottish study looking at all the cases, laboratory confirmed cases over a 5-year period, over 500 patients. 59% were admitted to hospital for a total of 2,700 bed days. There were 17 deaths, mainly in patients with acute on chronic liver failure, but from a neurological perspective, 37 patients presented neurologically, and 50% of these patients have long-term residual symptoms. What about causality? Here is some of the evidence for causality. We've got the number and homogeneity of cases over time and geographical location. We have case control data from in GBS. I haven't had time to go into GBS, but there it is. We see intrathecal antibody synthesis in some cases. In some cases, we find viral RNA, not just in the serum, but also in the cerebrospinal fluid. We see resolution of neurological symptoms with viral clearance in some cases. And there's a strain of hepatitis C which seems to grow anything, including neurological cell lines. So here we've got data from Germany showing hepatitis E growing on a range of cell lines shown up in green in the top panels. Some of these cell lines are neurological. We add ribavirin to the mix here in the bottom panels. It doesn't like it very much. Here we have some data from Holland. We have tagged hepatitis E. We inject it into the tail vein of a mouse, and then we scan the brain 72 hours later, and the brain lights up like a beacon. So hepatitis E appears to cross the blood-brain barrier, not only in humans, but in animal models too. My take-home message for you guys in terms of neuralgic amyotrophy: if you have a middle-aged male with acute, severe, non-traumatic shoulder pain and abnormal LFTs, you made a diagnosis of hepatitis E until proven otherwise, certainly in my clinical practice. I think we also need to consider that in patients with Guillain-Barré syndrome and some patients with meningoencephalitis, we should be considering the diagnosis of hepatitis E as well. I'll leave it there, Tom and Nick. This is always my final slide. Bear in mind, just read the small print very carefully.
Thank you very much for a wonderful presentation, Harry. There have been quite a number of questions. If you'd like to perhaps just stop sharing the screen now.
Yeah.
But I'll try and pick up on the questions. First of all, there's a pathological one from Alexandros. Is this a direct neurological effect or is it immunologically mediated? Are you able to answer that?
The answer is we're not absolutely certain. In neurologic amyotrophy, it's almost certainly immunological, I would have thought. But it's still an open question. The exact pathophysiology of this is not known. Okay,
and questions related to sort of why it's happening. Is this related to the genotype of the virus? Does that explain the geographical variation, or is it to do with the presence of pigs or something else?
The neurology is found throughout the world. It's best described in porcine zoonotic disease, so genotypes 3 and 4, but it also occurs in genotypes 1 and 2 as well, but it's less well documented. So the answer is it's probably a class effect of all the genotypes, but it's just been more well documented in patients with genotypes 3 and 4. Actually, I went back to look at Parsonage and Turner's original description of neuralgic amyotrophy, and it was published in The Lancet in 1947, and the subjects there were army recruits, and all the cases were largely from India. And 1/3 of those cases had bilateral involvement of the brachial plexus. But of course, this is well before hepatitis C was even discovered.
Yeah, so I think a challenge for our Indian colleagues, because there's so much hepatitis E in the Indian subcontinent, for some descriptive studies. Questions, several people asking, is the neurological phenotype seen in children? You said it's mostly middle-aged men, but do you see it in children?
I'm not aware of any reports from it in children at all. That doesn't mean to say it doesn't happen, Tom, but it's not been published.
And why this tropism for the brachial plexus and phrenic nerve?
Don't know.
Good, straight answer to that. There was a very practical question as when should we test for hepatitis E in patients with these syndromes? Would you only do it in people with abnormal liver function, or do you think we should now do it in everybody?
I think you should do it in everybody with neuralgic amyotrophy.
Okay, that's a very
everybody with Guillain-Barré syndrome as well.
Nick, just on that, and Harry, just on that question of tropism, Harry, is your feeling that it is actually the virus attacking the nerve, or do you think it's actually an immune response? And if you did nerve biopsies, I don't think you would necessarily see hepatitis E virus in there.
No, I think the paradigm of pathophysiology in GBS, for example, as you know, is immune mediated, and I suspect the same is true here.
Yeah, that's my feeling. And if anything, if one wanted to look for an explanation, it wouldn't be virus tropism. It would be some epitopes on those particular nerves that are shared with the virus or shared with virus when expressed in mammalian cells.
I think that's right, Tom. I think there are some patients who get encephalitis with it. These are usually patients who've got chronic disease, chronic hepatitis disease, so they're immunosuppressed transplant patients largely. And in some of those patients, you can find quasi-species compartmentalization, so that the virus in the CSF is actually slightly different to that you find in the serum or the liver. I think you can argue, stronger argue there, that this may be directly neurotropic. That's certainly a minority.
Okay, we're being flooded with questions here. I thank you all for submitting the questions. Just to let you know, Harry, there is a sort of forum online to take these questions further, and I'd encourage people to put that, and we'll post the details of that a little bit later on so that people can have their questions answered. I'm going to move on just because we need to keep to time, but thank you for a fabulous case. And something that perhaps some of us haven't thought about very much before. So thank you very much.
Thanks, Harry.
Going to move on to our second, this is a longer talk, and it's a great pleasure. Chris, if you want to start sharing your screen. Just to introduce my long-term colleague, Chris Parry, who is a very clinical microbiologist, has worked in many different settings all over the world. And has vast experience. Particularly relevant to this one is he worked with the Vietnam Oxford group for a long period when they were doing a lot of their studies on TB meningitis and other, but he's been a frequent speaker on our course in Liverpool, and look forward to hearing him talk today. Over to you, Chris.
Thanks. Thanks, Nick. Can you see the screen okay?
Yeah, it's perfect, thanks.
Okay, so thanks. Hello, everyone. I've been asked to talk a little bit about the diagnostic microbiology of CNS infections, and I give no apology that some of this will be a little bit basic, because I think it's worth reiterating simple things. So we're going to talk about, go to the next slide.
You might need to use your arrow advance, or possibly down on the bottom left if you're on display.
That's what I was trying to use. I know. Yep. Is that okay?
Yes,
that's working.
Thank you. So I'm going to talk a little bit about cell counts, gram stain, culture, PCR, antibody ratio, and metagenomics. So let's start with a case. This is a male baby born at 39 weeks by cesarean section for suspected preeclampsia. No other maternal history and actually no problems at birth. But at 16 days old, in the early evening, parents noted that he was crying more than normal and was agitated. And then within 2 to 3 hours became floppy. And so they took the child to the district hospital, where it was immediately apparent that the child was sick with mottled skin, poor capillary refill, tachypnea and some apneas, and a low temperature. And a respiratory acidosis, a high lactate, a low white count, a CRP of 80 that later rose to 334. So blood culture was taken, fluid bolus given, ceftriaxone and amoxicillin, and acyclovir started, and then dopamine was required, and the child was intubated and ventilated and transferred to Alder Hey Children's Hospital. A CSF was performed, but it was about 24 hours or so later when the child was more stable. So CSF was turbid and was sent to the laboratory. So what happens to it when it gets to the laboratory? So first part of examination, so normal CSF is of course clear and colorless as seen here. A traumatic tap, the blood clears between tubes. Turbidity is seen when the white cell count or the red cell count is raised, if there are a lot of microorganisms and also an increased protein. Xanthochromia, slightly different after centrifugation of the CSF, it's a yellow discoloration of the supernatant. So then a drop of the CSF is placed onto a slide to perform a cell count. So this could be a example, a Neubauer counting chamber, or even a simple plastic Cova slide. And on the wet microscopy, cells can be seen and counted and quantified by using the grid on the slide. So in this instance, the CSF was turbid in yellow with 3,780 white cells. By far, the majority were neutrophils with few red cells. The protein was raised at 5.16. The glucose was very low, less than 10% of the contemporary taken blood glucose. And a lactate was also done on the CSF, which was elevated. So let's just revise. We saw this yesterday with Fiona's talk. Just a little bit about interpretation of the cell count. So normal cell count, less than 5 cells in adults. You're allowed a few more in neonates, up to 20. And you can see the glucose and protein here. Again, you're allowed a little bit higher protein in neonates. So in bacterial meningitis, the cell count is elevated, above 200, often above 1,000, with neutrophil predominance, a low sugar, and increased protein. With the viral meningitis, the white cell count is classically less elevated, with a lymphocytic predominance, usually a normal glucose and normal or increased protein. Very early in enteroviral meningitis, polymorphs may predominate and then change to lymphocytes. Occasionally a low sugar can be seen. That's classically in mumps meningitis. The differential diagnosis in a lymphocytic picture, we particularly worry about TB, where the sugar is reduced, often very low, and the protein increase. And Cryptococcus can give a similar-ish sort of picture. But in this instance, the elevated white cells, predominantly neutrophils with a low sugar and high protein, is consistent with a bacterial meningitis. So what next? So then we would, if there's enough CSF, we'd like to centrifuge it, and with the deposit, put that on a microscope slide and do a gram stain. And this is the sort of appearance that we might see on the left, a low power view with multiple white cells seen. Slightly higher power, you can see the multi-lobe nucleus of a neutrophil. And then very careful examination of this CSF showed scanty organisms. So this is the picture here. I'm highlighting a little group of organisms, and just on the chat, I'd like you to tell me to describe what you see and then what organism you think it might be. This isn't polling, it's just on the chat, so hopefully Nick, you can help me.
GPC's gram-positive cocci in chains, most people are putting, in fact, pretty well everybody, and lots of people are putting a specific diagnosis. Do you want that?
So I've given some choices here.
Okay, so is this now a polling question?
But it's not linked with the poll.
Okay. So I can tell you that pretty well everybody has gone for gram-positive cocci in chains, and most people have gone for answer C. Okay,
that's good. So that's correct. So they're gram-positive. They're bluey purple in color. They're cocci, circular, and morphology. They're in short chains, which will be consistent with a streptococcus. And in this particular instance, the group B strat would be the most likely thing. So thank you. Okay, so what in the lab, what do we do next? So we can subculture the CSF onto agar plates and try and grow an organism. And if we do grow an organism, we can do identify it and do sensitivity testing. The main drawback of culture is that it's slow. It takes 1 to 2 to 3 to 4 days to get an answer. And in many areas of the world, culture facilities are not available. In reviews of acute community acquired bacterial meningitis, it's recognized most have an elevated white cell count with a neutrophil predominance. And gram stain sensitivity is reported to range between 60 and 90%, depending on the organism, experience, the numbers, and prior antibiotics. And sometimes when there's very scanty organisms, it requires a lot of patience to look through the smear to find them. I think 60 to 90% sensitivity is probably a little bit optimistic these days with prior treatment. CSF culture, pre-treatment is quite sensitive, as is blood culture, but pre-treatment is very common now, so I think these percentages are much less. This is an old study, a graph from an old study showing the time to sterilization of CSF following the administration of antibiotics, and meningococcus is sterilized by 6 hours or so, and group B strep and pneumococcus by 24 hours. So it's perhaps not surprising in our case. So we've seen some scanty organisms, but nothing growing on culture so far and nothing on blood culture. So what else can we do? We have available also molecular testing, and we can use single-plex pathogen-specific PCRs, such as viral panels, such as HSV, VZV, enterovirus, parechovirus are widely available. And in the UK, we have the meningococcal reference lab provides a meningococcal PCR service on blood and CSF. Both of those, however, for us, have a 24-hour or so turnaround time. So there are now a number of commercial platforms which provide a multiplex PCR. And at Alder for some time, we've been using the BioFire film array multiplex PCR meningitis encephalitis panel. This is quite easy to use. The CSF is put into the pouch, loaded onto the machine, and then it gives an answer in about an hour. And the multiplex panel covers a variety of bacterial causes of meningitis, Cryptococcus, and common viral causes of meningitis as well, as you can see here. So in our child, it was put through the film array panel and came out with the positive for strep agalacti or group B strep, which was consistent with our microscopy findings. So eventually we had a positive gram stain, but a culture negative on the CSF. The film array was positive with a group B strep, and indeed the blood culture taken on admission did eventually go a group B strep, highlighting the importance of taking a blood culture early on. Okay, here's another gram stain for you to look at. The reproduction isn't brilliant here. I'm highlighting a couple of organisms, and I just wonder what you think of this one.
So if you can put your comments in the chat here, what you think this is. I think we've got pretty much 100%. Chris, everybody's going for answer B, gram-positive diplococci.
Okay, yeah. Okay, so gram-positive again, bluey-purple color. They're slightly oval in shape, but cocci, and they're in pairs. They're a little bit like two arrowheads back to back, typical of gram-positive diplococci or Streptococcus pneumoniae. Okay, here's another one for you. Slightly higher power, and I'm highlighting a couple of the organisms.
Okay. Yeah, people are whizzing the answers in. I'll take a few more, but it's pretty much 100% heading for answer A.
Okay, so that's right. So in this case, they're pinky color, gram negative. They're cocci, slightly kidney shaped, and they're in pairs. So typical of gram negative diplococci or Neisseria meningitidis. Very good. For meningococcal disease in the UK, the availability of a singleplex PCR from the reference lab in Manchester has really transformed our ability to confirm diagnoses in the UK. We're encouraged to give antimicrobials as soon as we suspect the diagnosis, and meningococci do disappear quite quickly in terms of culture. And in this study from a few years ago now, the majority of cases were confirmed by PCR only. So this is our Alder Hey experience of using the film array over a couple of years. We don't see many cases of bacterial meningitis, but the group B strep, meningococcus and strep pneumoniae were picked up by the film array as well as by culture. We had an E. coli and Enterobacter that were not picked up by the film array, but were by culture. The majority of our positives are viral, enterovirus and parechovirus particularly. And the value of this is that it allows us to de-escalate antibiotics very promptly, and indeed often send children home quickly. It's pretty specific, negative culture and PCR in 160. This is another published study on the film array from Marseille, looking at 1,000 patients with CSF examined compared with standard tests. Again, the majority are enterovirus and parechovirus, only a few bacteria and a scattering of other organisms. The blue is where the film array agreed with the subsequent standard tests. The grey are those that were missed by film array, not very many. The orange were results that were difficult to interpret. Sometimes the film array can pick up a positive that is not entirely consistent with the clinical picture or the data. And then this is a diagnostic accuracy review recently published of 13 studies showing a sensitivity of 90% and a specificity of 97%, but acknowledging false positives and also false negatives. So this is not a replacement for other modalities for CSF culture, for example, but it does give a quick result when it's positive. Okay, I'll just give you another gram stain to look at here. So this is a child admitted with meningitis who was a refugee and had missed quite a lot of their vaccinations. And I've highlighted a little cluster of organisms there. I wonder what people think of this one on the chat.
Yeah, great. There's lots of answers coming in. Keep them coming, folks. I think, yeah, pretty well everybody, to start with, one or two people went for option D, Chris, but now everybody's going for option F.
Okay, thank you. That's the right answer. So a little bit more difficult. So these are gram negative, and there are some bacilli and some cocci, and they're quite small and delicate looking. So these are gram negative coccobacilli, consistent with Haemophilus influenzae, and of course the clue is the lack of vaccination. Haemophilus can be difficult to see on a CSF gram stain sometimes, particularly when it's scanty, because these are really sort of small, delicate looking organisms, and can be quite difficult to distinguish from the general crud that sometimes occur in the background.
Chris, can I just put in a chat question here from Tamador, who's really is asking, could Neisseria meningitis look like this, or is it always in pairs?
Almost invariably Neisseria is in pairs, so I don't think it would look like this. Sometimes other gram negatives can appear quite small and delicate, so you might, yeah, it may be difficult sometimes, but usually these are much smaller than other sort of Enterobacteriaceae and Pseudomonas and so on.
Okay.
Thank you. What can you do if you don't have a multiplex PCR or access to PCR machine? Antigen detection using latex agglutination tests are an old methodology that have probably fallen out of favor because of the availability of PCR. This is a WHO paper looking at the sensitivity and specificity of these kits with moderate sensitivity and reasonably good specificity. And I think in locations where perhaps resource poor locations where molecular testing is not available, I think these sorts of antigen detection test kits can still have a role. So if we move on to other pathogens on our list, so cryptococcal meningitis is important and common in some areas. So if a drop of Indian ink is added to the CSF in the wet prep, it can be possible to see the yeast with the large capsular halo around them, as seen in this picture. You need quite a lot of cryptococci in the CSF to be able to see this. But there are cryptococcal antigen tests available, latex agglutination and lateral flow assays, which are really very sensitive and specific and have really revolutionized the ease of diagnosis of cryptococcal meningitis. Culture may be slow, may take several days for the organism to grow if culture is available. And one of the other big sort of head-scratching diagnoses is tuberculous meningitis. Mike Griffiths is talking more about this later today. Suffice to say that if you do a acid-fast bacillus stain on a smear of the deposit of a CSF, the sensitivity is low. You can use a Zeal-Nason stain or a fluorescent stain, but the sensitivity is often less than 10%. If culture is available, you can do culture, but again, sensitivity is often low, and that's because of the low numbers of organisms in the CSF. Guy Thwaite some years ago did some work looking at what's the best volume of CSF to send to improve your chances of getting a positive culture. So the graph here shows that as you increase the volume of the CSF up to about 6 mils, you increase your chance of culturing the bacillus. Because of the scanty organisms, the length of time that you look at a smear is also important, and the longer you look, the better, although in a busy laboratory that may be difficult. The other trick that can sometimes be helpful is to do a layered smear of the deposit. So you take a drop of deposit onto a slide, you let it dry, you then add another drop on top, you let it dry, you add another drop on top, you let it dry, and maybe you end up with 5 layers of the deposit on the slide. And that can sometimes improve your chances of seeing the organism. Diagnosis of TB globally has been really revolutionized by the availability of molecular testing, particularly the expert MTB-RIF assays, which have become widely available. A very recent systematic review looked at the sensitivity and specificity of that. And the figures here show sensitivity and specificity, and also what would happen if you tested 1,000 people and 100 had tuberculosis, according to reference standards, which is culture. So the MTB-RIF, 71% sensitivity and 97% specificity, 99 people positive, but 28 without tuberculosis, but that's based on culture, which isn't a perfect standard. Specificity was 97%, 900 people, in 29 you would have missed tuberculosis. The XBit TB RIF Ultra has a slightly better sensitivity, lower specificity. So the test is not perfect, but it has the potential to be helpful in trying to build up a picture of whether somebody has TB meningitis or not. Okay, here's another gram stain. So this is a young child who had an external ventricular device, EVD, infection. Lots of organisms. I've highlighted one here. Any guesses on the chat?
Yeah, they're all charging in again. Pretty well, one or two going for A, but the vast majority going for D.
Yeah, okay. A little bit difficult. So, but the answer is D. So these are gram negative. They're pink, and the one highlighted is bacilli shaped. Some of them are looking a bit coccoid, but in Neisseria you wouldn't see that sort of bacillus shape. They're sort of short and chunky, which is consistent with an Enterobacteriaceae. In this case, it was E. coli that was causing infection, but you can't tell that on the gram stain. It could be another Enterobacteriaceae, Klebsiella or Salmonella or something. Pseudomonas would usually be thinner and slender, more delicate looking than these sort of chunky bacilli. Very good, all too easy. Okay, and here's another one. So this was an oncology child who presented with meningitis, and I'm going to just highlight one of the organisms here. Anything on the chat?
Yeah, there's plenty coming through. Everybody's engaging with this. Simple is best, Chris. It's really good to have this refresher. So everybody's going for E.
Okay, yeah. So these are gram positive now, and they're bacilli shaped, and they're quite small, again delicate looking, and that would be consistent with Listeria. Corynebacteria also look like this sort of shape. Different from Bacillus or Clostridia, which are big chunky gram-positive bacilli. So again, this is a Listeria, which is not a common diagnosis, and cases I've seen have not had as many bacilli in the gram stain as this. So if you can't see organisms, or you can, but you can't grow it, what else can you do if they don't come up on the multiplex PCR? So another route is to do a 16S or 18S ribosomal RNA gene PCR. So this essentially is a process of amplifying the RNA component of the 30S small subunit of a prokaryotic or eukaryotic ribosome. So you try and see if you can amplify a product from the sample, you sequence it and compare against sequencing libraries. So we don't do it on site. We send our samples off to Great Ormond Street Hospital, who provide a good service for us. And this has been our experience using this over the last few years. This is in 62 patients. We've had the following positives. So group E strep, Neisseria, meningitis and Haemophilus influenzae, so standard pathogens. In meningitis, we've had a group A strep and a brain abscess, Staph aureus and a shunt infection. We've also had gram negatives, Enterobacter and Leclercia, which we've ended up deciding were false positive results. And we also had a granulicatella, which was a slightly surprising result, but actually was a real result in a shunt infection in a child, where we subsequently managed to grow it from various samples. So this can sometimes be helpful to define an etiology. as we heard yesterday in the encephalitis and the meningitis talk, there are many organisms to think about. I've mentioned a few others here. If you're in Southeast Asia, then strep suis is the cause of virulent meningitis. In some areas, Enterobacteriaceae are important, like Klebsiella in East Asia, non-typhoidal Salmonella in infants in Africa. I've seen cases of post-op Pasteurella multicida meningitis in patients who had a pet dog that licked their ENT wound following surgery. Brucella is important in endemic areas. And then lymphocyte predominance, we need to think about other things like syphilis, for example. And in South Asia, rickettsia are important, like Orientia susugumushi or scrub typhus. So another approach to diagnosis is by looking at antibody levels. An example of this is symptomatic neurosyphilis. The results need to be interpreted with a history and examination, but you need a CSF not contaminated with blood and compare it with the serum. You're going to usually see an elevated white cell count, and you're looking to see if you get a positive RPR or VDRL in the CSF. False negatives are common. A TPPHA or TPHA, a negative result makes neurosyphilis unlikely, but does not exclude it. A positive result is suggestive of neurosyphilis, but isn't completely confirmatory. And in this instance, PCR is problematic. You can also compare antibody and albumin levels in CSF and serum. So calculate a CSF serum antibody index by comparing the pathogen-specific antibody in CSF and serum with total antibody in CSF and serum and giving an index to see if there's evidence of intrathecal antibody synthesis. The albumin CSF serum ratio gives an idea of the blood-brain barrier function. And this can be used in particular viruses and also in the diagnosis of a neurological Lyme disease. Even less common, occasionally in neonates, you can see a CSF pleocytosis associated with urinary tract infection with negative cultures from the CSF, but this is pretty rare. Occasionally, you might see increased eosinophils in the CSF. In eosinophilic meningitis, you usually expect to see at least 10% of the cell count as eosinophils associated with parasitic infections such as Angiostrongylus or methystoma. So a history of travel is relevant. You may look at the spun deposit of CSF for larvae, and there are serological tests available. So this one, I just want to show a quick video, if I can manage to do it. Here we go. Can you see that?
Yeah, just click the arrow, you're fine. Great.
So this is a wet prep of a CSF on a young Vietnamese man who'd come in with a severe encephalopathy following a few days before he'd been diving for pearls in a lake. And I don't know if you can see an amoeboid looking organism putting out pseudopodia. Is that clear, Nick?
Yeah, it's showing very nicely. Thank you, Chris.
Okay.
There's quite a lot of people interacting, giving the correct diagnosis on the chat show. One or two not getting it quite right. It's interesting. The names would suggest that most of the people outside Europe are getting it right, and some of the ones in Europe are not.
Okay. Let me just see if I can go back to sharing my screen again.
So I'll let you give us the denouement, I think, rather than...
So he had a primary immediate meningoencephalitis, which is usually caused by Naegleria fowleri, and is associated with swimming in fresh water. There are other free-living amoebae that can cause an encephalitis. It's usually a bit more of an insidious encephalitis, including acanthamoeba and Balamuthia. So you can see the motile trophozoites with the light microscope, and Giemsa and Wright stains and potentially acridine orange can be helpful. So, and my colleague in Vietnam, Jim Campbell, spotted those when looking at the CSF, doing a white count. Okay. Focal brain lesions, important to coordinate between microbiology and pathology and the neurosurgeon. Strep Milleri group and anaerobes are often common, but the differential diagnosis can be wide, including TB and toxoplasma and fungi and others. So the use of singleplex or 16S, 18S ribosomal RNA can in some instances be helpful. And my final couple of slides. So one of the newest approaches is next generation sequencing and metagenomics. And the idea of this is to amplify up nucleic acid from a clinical specimen, any nucleic acid that is there. So it's unbiased. You're not looking for a specific pathogen. You're just trying to see what's there. And this is still pretty much research still at the moment, but just to highlight a couple of studies. This is from China. 99 children with meningitis, where compared standard methods with CSF next generation sequencing, and was able to increase from 56 to 69% the number of confirmed diagnoses. And then this is a nice study from California in the New England Journal, where they looked at 204 patients comparing standard with metagenomic analysis, and picked up 13 cases diagnosed by metagenomics alone, and they outlined 7 cases in which the observations from the metagenomics made a significant impact on management. So I think in settings where molecular methods are available, I think this is going to become more mainstream in the future. So just to finish, so we've talked a little bit about CSF cell counts and gram stains, and I think it's important that that's the starting point for all the subsequent, often for all the subsequent investigations, and it's important to be able to get that right. Globally, in many resource-poor settings, labs struggle to even do that little bit correct, let alone anything else. CSF and blood cultures, the PCRs, the 16S and 18S ribosomal RNAs, the antibody ratios as a diagnostic approach, and also metagenomics. We're lucky in the UK, we've got really good virology and bacteriology reference laboratories who can help us with different difficult cases. But the final message is really to get the best out of your diagnostics, please talk to your microbiology team. Thank you.
Thank you, Chris. It's, you always make it sound so incredibly easy and simple, and I know it's not, so thank you very much. We've had quite a lot of questions coming in, and I'll try and take them in that sort of order of going from the basic through to the metagenomics, really. One early question was, how do you collect CSF for anaerobic cultures? Is that an issue? Do you need to do anything special?
Anaerobic infection in sort of meningitis is extremely rare. The main situation in which anaerobic culture is important is in relation to things like a sort of cerebral abscess or an empyema or something like that. And I think the key is to get sample as quickly as possible to the laboratory and up for culture. I think you want to keep it, the longer it's in the air, the more likely the anaerobes are to die. I guess with centralized laboratories, that becomes more of a challenge, but getting it into the culture as quick as possible is the best thing there.
Okay, and a question about cryptococcal meningitis. Is there any point in doing India ink if the CRAG is positive? Because in the past, there used to be technical problems with CRAG, weren't there?
I mean, I think the CRAG tests are pretty reliable now. I'm tempted to say probably not, apart from it's interesting to look at it if it's positive.
Okay, pretty pictures, but not necessary. Several questions about PCR. Start with the basic. Could you just re-explain the difference between multiplex and singular PCR?
Oh, sorry, yes. So singleplex is when the PCR is set up to look for a specific pathogen. So for example, you're just looking for meningococcus, or you're just looking for herpes simplex virus. A multiplex is where you're looking for a range of pathogens in the same reaction mix. So you have primers looking for viruses and bacteria, all in the same reaction mix. The advantage of the multiplex is that you're looking for a range of things. So in one reaction, you may pick out the thing that is positive. However, the multiplex is slightly less sensitive than a singleplex PCR. So for example, we have some situations where on multiplex, we're having a child with encephalitis, we're worrying about herpes simplex virus. The multiplex is negative for HSV, but sometimes we'll still send it to our virology reference lab for a specific herpes simplex virus PCR, which is can be a little bit more sensitive than the multiplex. I hope that explains it.
Okay, thanks. And there was a sort of related question. Is 16S or 18S less or more sensitive than a targeted PCR?
Yeah, so again, the 16S, 18S is slightly less sensitive than a targeted PCR. So in some instances, and we send samples to Great Ormond Street, in some instances for CSFs and other samples, we ask for 16S, but we also ask for targeted PCR as well to pathogens that we're suspecting.
Okay, thanks. A couple of questions about TB. Oh, sorry, just one further. Serum PCR, is that worth doing as well as CSF PCR? Viruses and bacteria?
For bacteria, it can be. So meningococcal PCR on blood can be useful. Occasionally we do HSV PCR on blood when for some reason we can't get a CSF, but it's not ideal. Other viruses, sometimes enterovirus can be picked up on blood. It's sometimes helpful, but ideal to get the CSF if it's possible.
Okay, there's lots more questions, but I'm just going to ask a couple of fairly basic ones about TB. Use of blood culture for TB meningitis, and also just to confirm that the slides you showed on expert TB were on CSF and not on blood.
Okay, thank you. So the comment about blood cultures, I wasn't quite clear. Is that putting a CSF
whether to use
into
blood cultures for diagnosis of TBM?
Okay.
Are they useful at all?
Yes, they can be in particular circumstances. So patients with HIV infection and advanced HIV infection often have a TB bacteremia, which may or may not be associated with meningitis. So in those patients, TB blood cultures can be helpful. For most TB meningitis, though, not so helpful outside the immunocompromised. The question about, so the expert data I showed was, and the systematic review was was looking at it in CSF.
Okay, Chris, there are other questions, some quite complicated, so I'm going to encourage people to resubmit those to the discussion group afterwards. I'm sorry we couldn't cover everybody's questions, but as always, awesome talk. Very great to refresh my failing memory, and thank you very much indeed.
Okay, thank you.
Thanks. So, so we'll now move on to the last speaker in this particular session. Laura, are you still there? Excellent.
I am indeed.
If you want to start sharing your screen, Laura, while I talk a little bit.
Sure.
So we were lucky enough to have Laura based in Liverpool for quite a while, and then she went off to Africa to do some research with the neuroinfection group and colleagues in Africa. And that was so successful, she's now a consultant down in London, and I think an intermediate welcome fellow, Laura, and senior lecturer.
That's right.
So she has a cryptic case called A Rising Tide with Consequences. How are you doing with your screen?
I am getting there. Just I'm waiting. I might have to
creaking along.
There we are.
Excellent.
Hopefully you can see that.
Yep. So yeah, just go to the slideshow and hopefully.
Great. We're there.
Excellent.
Okay. So hello everyone. This is a cryptic case, A Rising Tide with Consequences. I hope that will reveal itself shortly. I'm Laura Benjamin. Just some disclosures, just to say that this funding is not related, so has any implications to the case, and also to thank Arvind Chandratheva for sharing some slides of this particular case. So short and sweet, it's a 64-year-old man, fit and well, no past medical history. And on the 11th of March, he returned from a diving trip in Mexico via New York. He was short of breath on exertion. And this became progressively worse that by the 28th of March, he was admitted to hospital and desaturated, and soon after went into ICU and required CPAP. And on the 1st of April, he had transient right-sided weakness and pins and needles, paresthesia lasting for 20 minutes and then recovered from that. So just some clues to direct you in terms of giving you a gentle steer of where this is going. That's a chest x-ray he had on admission. And then he had some blood tests at the point of when he presented with his focal neurology, albeit transient. His white cell count was elevated, but not that elevated. He was slightly anemic. His platelet was normal. His CRP was particularly high, and his D-dimer was extortionately high. So bear that all in mind, and what we're going to try and do, which we did yesterday and trying to repeat it again, is that you go into breakout groups for 15 minutes. Is it 15 or is it less than that actually?
Okay, you just tell us what the question are and we'll give the breakout instructions.
Okay, so the first thing I want you to think about are what's the differential diagnosis? Think about in the context of the chest disease and the neurological syndrome. How would you investigate similarly with the chest disease and neurological syndrome? And then how would you treat for the most likely diagnosis? So those are my questions.
Okay, so just for the participants that weren't here yesterday or can't quite remember what happened yesterday, you will all now be assigned into breakout groups. That will happen automatically. The questions will be posted, but don't use the chat function, please, because that will be posted back to the group. When you get into your breakout room, please remember to turn on your camera and microphone, introduce yourselves to each other briefly, try and decide who might give some feedback, and then you'll have a long 10 minutes to discuss the 3 questions you see there, which I hope will... So welcome back, everybody. Remember that there were 3 questions. If you just go on to your next slide. So going to encourage people just to answer. So what was the differential diagnosis? If people can just put those on the chat, I will sing them out as they come in. Type 1 respiratory failure. We think there's chest symptoms related to COVID and CNS related to a thromboembolic event, COVID. Atypical pneumonia, dimorphic fungi and histoplasma, West Nile virus, wow. Neuroschistolegionella, Naegleria, Another one for histoplasma, a very wide range of differential diagnoses here. Fungal pneumonias, a lot of people linking fungi with chest and brain, I think, here. And some people going geographically for histoplasma, blasto, respiratory viruses, endocarditis. So there you are, Laura. There's a fair bit of stuff for you to comment on.
Great. I'm just moving the chat to have a look at. So I intentionally kept it vague because I think people, I snuck into some of the chat room and asking, was it 2020 or was it another time? And that was intentional, just to allow you to think broadly, because the way these cases present, it can be anything, but on this case, it's one thing in particular, which is obvious to most people. Having trouble moving my slides. So what's a differential diagnosis? So I'm going to approach it in a systematic way so that we consider everything. So I'm focused on the neurological because there's lots of things that cause chest infection, but then that narrows when you think about neurology and the chest as well. So he had a focal, a transient neurological syndrome, which could either be one of two things: a TIA stroke or a silent stroke because the symptoms resolved, or focal motor seizure that resolved as well. With a TIA stroke, it could be hemorrhagic or ischemic. I grayed out hemorrhagic because with a D dimer of 80,000, which is extremely high, this is probably going to be a thrombo event, an occlusive event. So ischemic is more likely. And with ischemic, it could be arterial or venous. And then with the focal motor seizures, it could be cerebral metastases, a cerebral abscess in the context of his sepsis, and ADEM as well. And also venous thrombosis could also contribute to seizures. These are things to think about. I've grayed out those areas. I think that's less likely, again, because the D dimer is so very high. Although a high D dimer could be related to cancer as well, but not as high as what we've seen. Venous thrombosis is possible, and things that can relate in the context of what we showed are dehydration, sepsis, hypercoagulability, and malignancy as well. And then in the context of, let me just move this off. And in the context of, I just got distractions here, of an infection arterial, this is a really nice review that thinks about it systematically. There are many ways an infection can contribute to a focal transient neurological deficit in the sense of an arterial stroke. It could be preceding or concomitant with a systemic infection outside the CNS, and that's probably due to a platelet activation trigger. Influenza, chlamydia, helicobacter can do this. It could be preceding or concomitant infection contiguous with the central nervous system. So Streptococcus homolymus influenza, Aspergillus, and this usually kind of occurs through a meningitis-like process that then leads on to a stroke through an endarthritis obliterans. Or they could just have a total burden of infection, and that increases their risk of stroke. And they usually tend to have vascular risk factors in that case. The infection can contribute to vasculitis, a HIV, varicella zoster, syphilis, Lyme disease, CMV, TB, neuroborreliosis. The list is endless. And in these cases, not all of them will cause a chest infection. Vascular remodeling, HIV, syphilis in particular, promotion of hypercoagulable states, hepatitis C, and infective endocarditis, which is very plausible in this case as well as cardiogenic emboli from, let's say, Chagas disease. But what's missing in this is SARS-CoV-2, which is obviously very much dominant infection in the last year. And these are the areas where it's most likely to contribute to stroke in this context, but we're still learning every day. It's probably likely to be a preceding or concomitant to systemic infection outside the central nervous system, or promoting a hypercoagulable state. So that is a whistle-stop overview of the differential.
Great. So I think the second question, we'll have to move on a bit because of time, was how would you investigate? I think was the second question. So I can ask the chat group just to feedback what will your investigations be. There's been quite a discussion about TIA versus stroke. between one or two protagonists on the chat.
Sure. We can have a chat
But
about that later.
I think we'll leave them to fight it out online. People are wanting blood cultures, tracheal aspirates, echocardiograms, everything they can tick on the box, HIV test, importantly, COVID testing, CSF, MR, CTPA, MR angiogram. So I think there's a pretty comprehensive list of stuff there.
Great. So pathogen, as many of you said, blood culture, HIV screen, and the list is endless. I think because of that geographical travel, it's probably worthwhile thinking about geographical panel, which is often done important down, and to think about the weird and the wonderful that you may not necessarily consider. But in this case, most tests were positive, but SARS-CoV-2 negative, and what SARS-CoV-2 was positive. So he had SARS. His imaging on day 14, the first time he presented with the TIA syndrome, when he had the MRI, he actually had a stroke, even though the neurology was transient. He probably had hyperprovision in the brainstem, but actually had an infarct in the cerebellum. And he also had some microhemorrhages. In these patients, you're already apprehensive because you can see there's a little bit of mass effect, and these patients are at risk of having hemorrhagic transformation, occluding the fourth ventricle, developing hydrocephalus, and can be fatal. So in this case already, we're already cautious and wary about this patient. With the D dimer that high, you should be screening for other causes of thromboembolism. So a CTPA was done, and as was carotid, the Doppler of his legs, and he had a PE, and that was on day 18. Now you can imagine the challenges that you face where the treatment for PE is anticoagulation, and his imaging looks like that. It was a decision that took a lot of deliberation, but he was started on anticoagulation. He had your usual stroke workup, clotting screens. He was lupus anticoagulant positive, anticardiolipin positive, and it also, I think, BT2 microglobulin positive as well. So he had antiphospholipid antibody reactivity. Important to stress reactivity because syndrome comes when you repeat it and it's persistently elevated after 12 weeks, which wasn't in his case. Standard vascular screening was normal, as was cardioembolic screening. Another complexity was added to this case because on day 20, he presented with a homonymous hemianopia, and you can see he had a further stroke. And then you think, okay, he's got raised D-dimer, you anticoagulate him. We've given him anticoagulation already for his PE, so why is he having a further stroke? And then, you know, if the choice is to increase the anticoagulation further, then you're a bit wary because of the scenario that I've described here with that ticking bomb. So just to justify my title, and especially on this side, just to show, demonstrate the rising tide, he presented with his stroke on the 1st of April, and you can see the D-dimer peaks around that time, as does the CRP, and then you see the reverse with ferritin, where it reaches its ferritin is also elevated, and lymphocytes reaches its nadir around that time as well. So there's definitely biomarkers that point to a thromboinflammatory process in his case.
So Laura, I think we just move on to your final slides. We'll have to leave out the remainder of the interactive discussion just because
Sure.
of time.
So how would you treat it? I think it's a bit of a misleading thing because I've given you more information. These cases are complex to manage because once they've had an ischemic stroke, and we know that giving anticoagulation could cause harm in these patients. So it's something that has to be taken worked through carefully. We developed a protocol to try and give some guidance at the first peak of the pandemic, and I think it still remains relevant. And in this case, what you find is that he presented with his stroke syndrome on day 14, and often these patients are maybe PCR negative. So then you have to rely on other things like serology, which may not be sensitive enough, and sometimes D-dimer as well. Most stroke patients D-dimer less than 1,000. So if it's greater than 1,000, it should introduce a discussion to look a bit harder. At least look for the antiphospholipid antibody, the biomarkers that we know are associated with COVID. If they have significant hemorrhage, then you're not going to entertain anticoagulation. then they may be on anticoagulation. And we saw that in some patients, that you have to make sure that's fully optimized by looking at factor 10A and making sure it's adjusted to their weight. Then look and explore for other causes of thromboembolism, such as PE and DVT, as we saw in this case, and then treat it accordingly with anticoagulation. If there's no PE or DVT, then it's a case of monitoring that D-dimer, and if it keeps on going, increasing exponentially, then using a kind of structured discussion in the vascular MDT, rationalize whether you need to think about anticoagulation in this patient. So just to bring that all together, we think COVID has different ways of contributing to strokes, but we think the unique way that COVID contributes to stroke is in this case that we've just described. And there are lots of data emerging to show that they tend to be large vessel occlusions, they tend to be multifocal, and they tend to be associated with systemic thromboembolism. They sometimes, but not always, have positive antiphospholipid antibody, but we think this is likely to be an epiphenomenon like we see in other infections like HIV. And then they're likely to have a delayed presentation from the respiratory onset occurring in the para-infectious phase of the illness. Anticoagulation may be required, complex decision-making process, recommended vascular radiology, MDT to guide management. And that's it, thank you.
Thank you very much, Laura. Yeah, it's one of the comments was it's always COVID in 2020 and 21. My view is that it's a little bit like Chardonnay, ABC, anything but Chardonnay. For me, it's anything but COVID. But thank you for taking us through a really complex case. I think we won't take further comments now, but just to remind people that you can continue the chat. If you go back through the chat, and we'll put it up in during the break, there is a discussion group. And also just to remind you that recordings of all of these will be available next week, and we'll give you a bit more detail later on. I think welcome back, everybody, to this second session of the second day of the virtual NeuroID meeting. There are a couple of changes. First of all, Rachel Neen was going to be chairing this session, but unfortunately she's had to go off to the ward. So I'm going to co-chair this with Tom. I'll chair the first couple of talks, and then Tom will take over. Secondly, Chrissy Burness, who's a neurologist that works between Walton Centre and the Infectious Disease Unit, among other places, is also been occupied with clinical work. And so Tom is going to do another case in her place, although I'm rather hoping she might be able to sneak in and join us. I can see that Tom's got his slides up already, so I think we'll introduce the other speakers as we go through rather than doing a round robin. So Tom, over to you.
You need me to, are you seeing one slide or lots of slides?
Yes, we're seeing the whole screen. It's good.
Perfect, great. So thanks very much. This is a case that we saw here in Liverpool from a couple of years ago. It's a 39-year-old woman who presented to a hospital near us with leg pain, which had been going on for 4 days in the left leg. It started in the lower back and was radiating and was getting quite severe. She'd had a headache and vomited once. She'd had 4 months of intermittent diarrhea, which started 2 weeks before she went on a trip to India, where she'd eaten some dodgy mushrooms. But she'd since come back and had a flexible sigmoidoscopy and gastroscopy, both of which were normal. And the past history, functional inquiry, family history were all unremarkable. On examination, her temperature was 38.5, and she had a painful left leg. It was weak and flaccid and areflexic, and there was a loss of sensation in the L4 to S1 dermatomes. The rest of the examination was unremarkable. So at this point, I think we would like people to suggest in the chat, first of all, what diagnoses they're thinking of, and then we'll move to a poll.
So I'll read them out as they come in, Tom. I'm not sure if you can see it. I've had CMV, enterovirus, schisto, enterovirus 68, rabies, enterovirus, a lot of people going for that, TB, polio, enterovirus, disseminated TB, psoas abscess, HIV, West Nile, Campylobacter, epidural, VZV, shingles, A fairly good collection of things there. SOAS collection, a lot of people worried about that.
Okay.
Photobiology, even the
Well,
leprosy.
let's move to the poll then. So these are the options in the poll: a prolapsed disc, spinal abscess, Guillain-Barré syndrome, polio, or other. So vote now.
Okay. Wow, it's a bit of a fight for the finish line here. Much wider spread of answers than we've had in some of the other polls. So we'll keep it going for a little bit longer, I think, just because there's quite a lot of
Yeah, we've got 260 out of 400 people voted, so we'll just give them a little bit longer. So, all right.
That'll do it.
Let's stop that there and share that. So you can see that prolapse disc was the least popular, spinal abscess the most popular, but also Guillain-Barré syndrome, polio, and other quite popular. And I guess among other, we heard people mention enteroviruses and other things. Well, let's see how the patient did. I'll have to just go back one. It's jumped forward too. They were given morphine for the pain. And they had a CT scan which showed no disc disease, and they progressed. They developed a sore throat, had difficulty swallowing, goose pimply rash on the skin, bilateral hearing loss. On day 8, they referred to the medical team in the hospital, who noted that the patient was now lethargic and had flaccid weakness in both legs and arms. They made a provisional diagnosis of Guillain-Barré syndrome and started treatment with intravenous immunoglobulin. And then they did a lumbar puncture, which showed an elevated cell count marginally, but otherwise, and an elevated protein. On day 11, she had increased drowsiness and was intubated and ventilated. And they noted at this stage she had absent oculocephalic reflexes and unreactive pupils. The CT scan of her brain was normal, and they contacted me on that day for advice. So at this point, there's no poll, but maybe at this point, we'll just allow people to extend their diagnoses or revise them if they want in the chat. And I can see we've got a Miller-Fisher variant, botulism, Bickerstaff's, which is a brainstem encephalitis, diphtheria, BBV, I'm not sure what BBV
Bloodborne
is.
virus.
A bloodborne virus, okay. Listeria, rabies, Campi. So quite good to see a great range of possible diagnoses. A few people have mentioned rabies along the way in the chat. Would people like to in the chat say why they've mentioned that? Anyone that's mentioned that as a possibility? And the point was,
India and puppy nip.
yeah, the India and the puppy nip. So there was something in the history that I didn't draw masses of attention to, although it was written down. And in India, she'd had a nip by a puppy. So when the local hospital contacted me, they also mentioned this as an afterthought. They said, we've got this patient. We think she's got some kind of nasty Guillain-Barré syndrome, but she was also nipped by a puppy, and the husband keeps going on about that. And they said, we don't need to worry about rabies, do we? And I said, the truth of what I said is, I think we do need to worry about it, but she'd have been very unlucky because there are other things that also we should consider in terms of an ascending GBS-like illness, which then affects the brainstem. So Miller-Fisher syndrome is a Guillain-Barré variant. Bickerstaff's is, if you like, a variant, an autoimmune brainstem encephalitis. So I said we should get some saliva, serum, and particularly a skin biopsy to look for rabies. Which then had, we did PCR on that. We should bury a nurse her in case it was rabies and transfer her to our centre. And at that point, I thought we'll confirm the neurological diagnosis. And if it is rabies, then we should potentially try a new experimental treatment. But the honest truth is, it's always easy with the retrospectoscope, but the honest truth is, I thought we had to exclude it rather than, oh, this was definitely going to be paralytic rabies. But this being a neurological infectious disease course, it was, of course, paralytic rabies. So this is a picture of a skin biopsy, which we usually do at the nape of the neck because the hair follicles there tend to be stuffed full of virus antigen. And we did some imaging, which you can see here, showed hippocampal high signal here, you can see in both these images. And then also we did where are we? Here there are high signal at the head of the caudate. And again, these are, you don't get many MR images on patients with rabies virus, but these are pretty typical patient changes. And then the PCR, as you can see on the next slide here, there's a band for the positive control at 603 base pairs. And she was positive in her skin and also in her saliva. We sequenced the PCR product, and you can see on this slide here, this UK ex-India case was very close on the phylogenetic tree, the family tree, to a patient that had come from India to Germany earlier in the year. By this stage, the PCR had confirmed the diagnosis. She was unfortunately too sick for any experimental treatments, and we withdrew inotropic support, and she died on the 18th day of admission. And she'd never had hydrophobia, so this was a classic case of paralytic rabies. The post-mortem needle biopsies, which we did, also confirmed the diagnosis. And I'll just show you here. So day 15 was the first day of our sampling, and we repeated sampling every day, which is what you should do with these rabies patients until you have a definite diagnosis, because it may be that your first sample will be a false negative, but you can see she was positive. Also, the brain biopsy samples, but CSF was negative, which it often is. And we also did fluorescent antibody testing, neutralization antibody testing, which was very low until just before death. And this is one of the problems with rabies. This is why people die, because they don't make a sufficient immune response. This being a patient, returning traveller to the UK, she, of course, was BBC News, unlike the 40 to 50,000 patients who die every year in endemic countries and don't travel to the UK. So I'm going to just say a little bit about rabies, and then there should be some time for a bit of discussion. Epidemiologically, rabies is seen in all these countries here in the dark green. The light green countries are said to be rabies-free, and they're rabies-free in the sense that they're free of rabies virus, but there are other rabies-like viruses, such as European bat lyssavirus, in some of these other countries, which can cause rabies, the disease. So this is a man who caught the disease after a European bat lyssavirus infection in Scotland. And so as well as European bat lyssavirus, there's an Australian bat lyssavirus, meaning that, again, you can get rabies-like disease in Australia, even though it's free of rabies virus. This is the Daubenton's bat, which is a carrier of rabies virus in European settings. And this shows you the different genotypes of lyssavirus. So the classical rabies virus is genotype 1, and this can be found both in dogs, terrestrial mammals, but then also in bats. And the within the genotype, the bat rabies viruses are a little bit different to the dog rabies viruses. And then we've got these other genotypes, the European bat lyssaviruses I talked about, Lagos bat virus, which doesn't cause human disease, Macola, which seems to only cause an encephalopathy, but the other ones cause rabies, the disease. It's a rhabdovirus, it's a rod-shaped virus, hence the name. It's transmitted naturally among insectivorous bats, and you can find up to 8% of bats are seropositive in some populations, so clearly they don't all get sick of the disease. It then spills over into a cycle in wild mammals, which is now well established, and then occasionally spills over into domestic animals. And most human infections follow bites from domestic animals. It's a particularly big problem in India, where there are up to 20,000 deaths reported, 60% of them children, and there are about 8 million exposures to dog bites in India. So you can see it's a really challenging problem here. The reported figures are probably an underestimate. Malawi was said to have no rabies at all, but that's because nobody was testing for it. And when we did a study looking for rabies among patients with suspected CNS infections, this was done by Matt Malewa, one of our fellows a few years ago, he found 10% of the fatal CNS infections were due to rabies virus, including, importantly, patients who were diagnosed as cerebral malaria because they happen to have malaria parasites in their blood, but when you did a brain biopsy, you found rabies virus. So the virus enters following the bite of a dog. It's then transported centripetally up to the brain. It replicates in the brain and then is transported centrifugally throughout the body, including the skin, which is useful for diagnosis, and into the saliva, which of course in dogs and mammals is very important because that's then how it's passed on. The routes of inoculation, broken skin following a bite, or also via mucosal membranes and occasionally via transplants. Tragic stories of people who had died from a brain disease and it was not realized to be rabies, and so their organs were then transplanted into others who then developed rabies, the disease, and it was clear that the index case was somebody who died without it being diagnosed. The incubation period varies from a few months up to many years. Typically, though, it's 2 or 3 months. One of the earliest clinical features is skin itching and pain around the site. And you can see from that image there, it can be very, very itching, very much, which causes a lot of scratching. The clinical features of furious rabies, which is the classical rabies that most people will be familiar with and accounts for about 70% of rabies, are shown here. There's confusion, patients are agitated, but also in between periods of confusion, they're completely lucid. They have autonomic stimulation with excess salivation and frothing, and they have the characteristic spasms in response to water being presented to them. So this is hydrophobia. They also have aerophobia. If you blow on the skin, if you're not sure whether a patient has rabies or not, you can blow on their skin and that will cause a spasm. And this is an image here of a patient having a spasm in response to a drink. The differential for furious rabies is shown here. It's brainstem encephalitis or other causes of pseudohydrophobia. You get people who think they've got rabies even though they haven't. Paralytic rabies accounts for about 1/3 of the cases, and this here is a summary of the clinical features, which were really what we saw in our patient. And the differential is quite broad, including features that were mentioned in the chat, but also polio we heard mentioned, other enteroviruses, etc. Flaviviruses can cause myelitis, spinal cord damage, which can look similar. The diagnosis is usually clinical in most of the world, but if you can do a skin biopsy, as we could do in our patient, then you can detect the virus by PCR or by an immunofluorescent stain, as shown here. Just a word or two about treatment. For the most part, patients are sedated. My professor of neurology of tropical medicine who taught me said you should sedate them and then lie through your teeth about the diagnosis. Because they have lucid intervals, they will ask you whether or not this is rabies. I think most people now feel that we should actually be honest with our patients, and barrier nursing and vaccination of any staff who may have been exposed. Finally, recovery from rabies. Well, there were 5 cases of people who recovered, but they got post-exposure vaccination. And really, this could be seen as a failure of their vaccination regime. And it used to be said that everyone who develops clinically rabies who's had no vaccination will die. But then there was this patient who was treated in Milwaukee in Wisconsin. And this was a girl who'd been bitten by a bat. She'd not been vaccinated. She developed clinical features of rabies. She had this cocktail of drugs and she survived. And indeed, if you want to know more about her, you can go and read about her on her website. But since then, this Milwaukee protocol has been tried on many other patients, and it's not really been proven to be successful at all. It's almost always been a failure. So our approach would be not to attempt any of these protocols. I'm going to stop there so we have a few minutes for discussion. I'm not going to say anything about rabies vaccination. You'll be familiar, this was the very first vaccination of humans and was instigated by Pasteur. What I would say though, there's recent WHO guidance on who should get rabies vaccination, published in 2018, and you can find that on the web. And the vaccination regimes are quite complicated at the best of times, so I would recommend people looking them up if they want to. Just a word about rabies control. Vaccination of dogs, mass vaccination of dogs, is a very good way of controlling rabies. And I'll stop there. Thanks.
Thanks, Tom. We've just got a couple of minutes of questions. I'll pick up on some of the things that have come through on the chat. Several people asking about focal lesions in the limb that's bitten, the relevance of pain in the bitten limb, and also whether goose pimples, that funny skin reaction, limited to the limb that was bitten, or was it a more general thing?
Yeah, so the limb that's bitten is the one that typically will have the pain and the itching, and and then if it's paralytic rabies, that's usually where the paralysis will start, but then it can spread to other limbs. The goose pimpling was all over and can occur in any rabies, and it's thought to be a form of autonomic hyperactivity, such as the hypersalivation that we see.
Okay, and somebody commented, did she get any vaccination or immunoglobulin in India?
She had nothing in India, and when she came back to the UK, she did sadly go and see her GP, who could have vaccinated at that stage, because it's never too late to offer vaccine. But unfortunately, the GP didn't pay too much attention to the puppy bite.
Yeah, and that's occurred in other cases in the UK, so that's a very important message. People have asked about testing for lyssaviruses, similar or different?
Similar in the sense of PCR testing. So we've had Duvenhage recently in Europe, and tested by PCR, and the clinical, where if they develop a rabies-like illness, it's clinically very similar.
And are lyssavirus infections also 100% fatal in people?
No, it depends which virus. So the European bat lyssaviruses are nasty. Some of the other ones are, Macola is much less likely to cause severe disease.
Okay, and the final question about vaccinating exposed staff. Why would you not offer vaccine to all staff?
That's a very good question. It's always an issue. We have a returning traveller with rabies every few years in the UK, and you spend as much time looking after the patient as you do dealing with the public health response. And so although the Public Health England guidance is about vaccinating exposed staff only, our approach when I've been involved has been to say we will vaccinate anyone who wants it, because otherwise you spend hours in discussions with people, and anyone who, so certainly those who were exposed in the sense of looking after that patient, they must be vaccinated. But you'll find a nurse walked past the patient on the corridor, or as the patient was being wheeled to the morgue or something, or an ambulance driver is very anxious. And my feeling is anyone who's anxious, it's easy just to vaccinate them.
Great, thanks, Tom. I'm just going to finish with a note from Wasim on the chat. Important message to people coming to the Indian subcontinent. Don't hide any animal bites, however insignificant you think they are. I think that's a very good final message. Thanks for a wonderful presentation, Tom. I'm going to move on now to our next bigger talk of this session. Mike, do you want to get your slides up? So
Yeah.
it's very nice to welcome Mike Griffiths, who's a senior investigator with the Neuroinfections group in Liverpool. He's had a particular interest in pathogenesis of bacterial and TB meningitis, and is going to talk about tuberculous meningitis. We can see your screen, but it just needs to be made bigger.
Is that okay?
You're not yet on full screen. That's good. That's perfect. Thanks. So, Mike, just to let you know, I'll sing out from the chat if there is any interactive stuff in this. Okay.
Okay, so there'll be some interactive stuff for the case that starts it, but beyond that. Okay, so as Nick said earlier today, he got a bit bored of COVID, and we all know that TB is probably one of the long-time historical scourges, and we're going to give you a bit of information around that. I'm going to start with the case. So I want to talk you through about a 5-year-old girl. Before she was seen 6 days ago, she had an intermittent headache and sleepy. This initially improved with paracetamol. In the last 2 days, the headache has become more persistent, and mum has reported her being increasingly sleepy, sleeping during the daytime on the sofa. 1 day ago, her GP gave her amoxicillin for otitis media. Because she wasn't improving, her parents brought her to the local hospital. She complained of a worsening headache, mainly at the front. She was sleeping at the time, but easily rousable by touch. One would say that she wasn't cooperative when you're trying to get her to stand up. She'd rather just lay there and was a bit combative. There was no obvious neck stiffness, no obvious photophobia, and there was no rash. At the time, the cranial and peripheral nerves were intact, and her temperature was 37.9. So given that history, I just wondered if people could answer in the chat what they would have for differential diagnosis. Obviously, that would be broad, and then after that, we'll move on to other questions.
Okay, so if people want to chat now with possible differential diagnosis, I'll sing them out. I don't know if you can see them, Mike, but I'll sing them out anyway. Brain abscess, bacterial meningitis, encephalitis, mastoiditis, TB meningitis, viral meningitis, meningoencephalitis, if you can distinguish between the two.
Yeah, true.
Bacterial meningitis, query ear source, ADEM, somebody has suggested.
That's good.
Sinusitis with meningeal irritation. And I think perhaps a good comment to stop on, need more information. So do you want to talk about differentials?
So I think the differentials are captured very well there. Obviously, we always have to think about local pathology in your teeth or your mastoids or your ears or your sinuses. That's good. But you should also think about a broad range of meningoencephalitis. As a pediatrician, I don't really believe in the distinction between meningitis and encephalitis in young children, and you often get a mixture of symptoms. So I think you've captured the broad range of viral, bacterial, TB, so that's good. At this point, would you consider any investigations, and would you consider any treatment?
So let's have the investigations first. So we've got MR and LP, cerebrospinal fluid, complete blood picture, C-reactive protein, bloods, cultures, imaging and spinal fluid, malaria parasites.
Good.
CSF and gene expert.
Okay.
CT followed by LP, and then a wide collection. Bone marrow, somebody's put. That's interesting.
Quite extreme. Okay. Okay, well, that's a good start. I'm slightly worried that one of the first questions back was one of the answers back was an MR. I think we should start with simple tests first, and I would be thinking about you doing blood tests. And obviously, key to investigation of CNS infection are lumbar punctures. And as I hope has been emphasized in the course already, you should be able to clinically review whether you feel they're safe to do an LP, and only if you don't feel they're that to then move on to investigation. So I'd worry about doing you don't want to delay the LP by doing a CT or MR unless you have to. So I think those list of investigations are good. Would anybody consider treatment?
So what treatment would people start? Just pop that in the chat. We've got one would wait for LP, one would give IV ceftriaxone. There's a question, was there any history of head injury, which I think is a fair question.
Good.
So I'm going for acyclovir and ceftriaxone, several people doing that. Kef and Vanc, somebody has suggested.
Okay, that's good. So I'll now move on. Thanks for your input so far, guys.
You're not advancing.
Okay. So at the local hospital, can you see that slide? Sorry.
That we can now. Yeah.
Yeah. So at the hospital, she continued to spike temperatures. They were pretty high. They're up to 38, 38.7. She continued to be miserable and lethargic. Although she had formal photophobia, she definitely wanted to keep her eyes closed. And so when people put the lights on, she wasn't opening them in that sort of environment. So you could call that possibly photophobia. She complained of a persistent headache. And again, that was worse when you moved her head. So again, although she's not formal meningism, the very fact that when she was moving her head, it ached, you'd think about that. She'd started to vomit and the GCS was a little bit down at 13. The bloods came back with a white cell count of 9.4. U&E showed a sodium of 134, which dropped to 130. CRP wasn't particularly impressive at 2 and 8. Sadly, they had 2 goes at a lumbar puncture, but both failed. And then they also undertook a cranial CT, and that was reported as unremarkable. Like a lot of you suggested, so we've had bloods and a trial and an LP, and she was started on ceftriaxone and acyclovir to cover for either sort of bacterial meningitis or encephalitis. On day 4, things hadn't really improved. She was still feverish, her sleepiness persisted. The good news was that they'd managed to get an LP at this point. Red cells were 35 cells per millimeter cubed, white cell count 195, protein was 0.63 grams per litre, and glucose in the CSF was 1.4, and the BM, we didn't get a peripheral plasma glucose, but the BM was 6, given a ratio of 0.23. So does anybody have results, what do they think about the results of the LP? Does that guide you in your diagnosis?
So we're getting people saying viral meningitis could be lymphocytic with low glucose is a bit suspicious. Treat for bacterial, but not surprisingly, a lot of people are saying it's consistent with TB, especially that very low glucose or partially treated bacterial meningitis. But I think increasingly people are focusing on TB, with the odd person mentioning fungal disease.
So that's great. I mean, irrespective of the fact that it's a BM rather than plasma, I'd be really worried by this ratio being down at 0.2, and that would really drive me towards a worry about TB rather than viral meningitis, because of the state of the patient. Predominantly, she's sick. It isn't a typical line of a viral meningitis. Now, we know that mumps can cause low glucose, but you wouldn't expect her to be that unwell. And then that fits with a high protein, and it fits with a raised white cell count, but it's predominantly lymphocyte driven. So that's good for my audience. On day 6, she's still on IV ceftriaxone and acyclovir. She's still sleepy. She doesn't want to open her eyes. Fever's still raging at 39, and her sodium's 132. At this point, would you want to repeat any investigations, or indeed would you want to alter treatment?
So we'll ask for comments on the investigations first. Chest X-ray has been mentioned before, and again now. Gene expert, ultra and biopharm people want to do. Lots of people now wanting to do an MR or a CT scan. People concerned about hydrocephaly in particular. Lots of people wanting to do TB studies on cerebrospinal fluid, blood cultures.
Has anybody wanted to start TB treatment?
No, I asked for the investigations first.
Sorry.
So, okay, what about treatment then? So before we talk about the investigations, can I ask people commenting, would they start TB treatment now, or would they wait for further tests? So most people are saying yes, but try and get in there and get some more samples off rapidly before you do it. I think that's the general consensus.
Excellent.
And a few people are adding steroids, but that's basically it.
Okay. So what happened in real life was that they didn't do much. The child continued to deteriorate. She's now had double vision. She complained of seeing 2 of mum. She complained of feeling dizzy. And as they went back to review her over the course of the evening, her GCS drifted from 13 to 11 to 3. So unfortunately, she was still, unlike what the audience has said, she's still on IV ceftriaxone and acyclovir. We haven't repeated any investigations at that point, although I think that was well worthwhile. And most importantly, we haven't started any alternative treatment. So given this rapid deterioration, what would you do now?
Quite a few people saying call a neurosurgeon and intubate, not necessarily in that order. Again, people wanting imaging, but clearly people are recognizing this is severe and going downwards rapidly. A few people saying anti-TB treatment. So quite a mixture of things. Most people intensive care.
Good. So they did get their act together now, and as you've said in the audience, the key thing now is to stabilize and manage this patient. You've had a rapid deterioration of GCS, so that wouldn't be an indication to go for imaging. You'd want to stabilize, you'd want to intubate, and you may also need ventilation. As people have past said earlier on, it would be a good opportunity to think about dexamethasone at this point, because you'd be worried about both hydrocephalus and brain swelling. And as you've rightly said, what we need now is a neurosurgeon. So we need to try and transfer to the neurosurgeon so that they can manage this rapid deterioration. And the deterioration is probably either due to rapid cerebral edema or hydrocephalus, both of which could be managed by that specialty. This was the scan that was done just before or on entry to the Alderhay once you've been stabilized. What do you think about this scan? Any comments on it? I guess to start with, is it normal or abnormal, and then what changes?
Raised ICP, cerebral edema, lots of people saying.
good.
Effacement of the sulci, brain,
Good.
diffuse cerebral edema.
Good.
Yeah, everybody's
Okay.
agreeing, I think, there.
So I think we'd all agree that this is an abnormal scan. As you've rightly said, the brain looks like it's squeezed. You've got the loss of the grey-white differentiation. You've got that effacement against the skull. So that's looking bad from a cerebral edema point. There's also a few things that may give you a bit more information. There's 2 areas of hypodensity in the basal ganglia, which I've highlighted the yellow arrows. And there's also some high signal in the straight sinus, which may suggest there's inflammation around the wall of the vessels and may think about sort of an inflammatory process.
Yeah, the audience have picked those out, actually. Congratulations to those who picked them out earlier on.
Well done, because that's tough. So that's good. You've done better than the local hospital there. So at tertiary hospital, it was now day 6, or importantly, day 11 on their illness. Their GCS was a little bit better on intubation, and she recovered slightly. And so the GCS was 12, and she was opening her eyes to speech, but otherwise keeping them closed. She had inappropriate words, and she was moving to commands. She had a clear right 6, or abducens, and a left 3rd, and that was probably why she had a double vision. They did an LP, and he had an opening pressure of 37. White cell count was 54. There was newts of 10, monocytes of 44. The surgeons got in and did an EVD for hydrocephalus, and they started immediately their anti-TB drugs. Now, importantly, that at the same time, they pulled off samples for CSF, and we got an IGRA result back, but sadly the result was indeterminate, didn't help. As we all know, that's not often that useful in acute disease. And the MTB was grown, but it wasn't grown until 6 weeks later. So they were treating blindly from the results for quite a long time, but they were treating appropriately. So the outcome from this child at 6 months post-hospital discharge was, sadly, she was able to sit without support, but she wasn't able to walk independently. She had a mixed movement disorder where she had some stiffness and some additional movements, and she had a speech impairment. Since then, she's made gradual improvement, but she still has some walking difficulty, and she still sadly has some speech impairment. So that was a case to tell you about the disasters that can be associated with TB, and then I'll move on to the talk.
Can I just, a couple of questions from the audience, Mike. One was, what were her risk factors for TB? Were there any?
So she was actually a Caucasian girl. She was from the northwest of England, in a relatively poor economic group. She didn't have any history of drug use, or indeed did her family. But on the public health testing in the future, they did find there was a contact in that one of the elder children linked with somebody who did have TB, and they thought that's how that she got exposed to it. Importantly, she wasn't of ethnic distinction, and she hadn't previously travelled to an area of high TB incidence.
Okay, thanks.
Okay, so as I'm sure you know, it's probably still true that TB is one of the diseases of highest impact on health. As we all know, there are challenges of TBM diagnosis. I'm going to give you a little bit more information about cranial imaging, and then go through some basics on treatment options. So, as you all know, TBM is a devastating disease, and TB meningitis is probably one of the most severe forms of TB. It's got a very high mortality, between 10 up to 65%. Survivors frequently suffer neurological sequelae, 30 to 50%. In the first-year mortality in a Vietnamese study, in HIV sufferers, it was 65% mortality, and non-HIV, it was 30%. And over 50% of those survivors suffered long-term disability. And back in the UK, it's not pleasing to know that we're probably one of the cases that historically, since 2000 to 2012, we had rises in cases of TBM, and we still have one of the higher rates of TB prevalence rates in Northern Europe. Now, as my case sort of highlighted, there's a real need to diagnose promptly. And we know that delayed diagnosis or delay in starting treatment initiation leads to a poor outcome. Similarly, if you have an incomplete course or interruption to the course of treatment, you have a worse outcome. Similarly, if you have people such as chaotic or economically poor or drug users with poor adhesance, again, you have worse outcome. And as we know, if you're immunosuppressed, you have co-infection, or you have a drug-resistant strain, again, your chances are much worse. And the need to diagnose and treat promptly just can't be emphasized enough. It's been shown before that if you come in with the modified MRCE criteria, so the sort of grade 1 where you're alert and orientated, and your GCS is 15, outcome's good, 100%. If you have impaired consciousness, it goes down. And if you come in with significantly impaired consciousness, a GCS under 10, or with focal neurological signs, outcome is poor, with only 47% of people having a good outcome. This is actually the follow-up scans of the girl I showed you. And as you can see, despite the fact the neurosurgeons put in an EVD for hydrocephalus, it continued in the fact that we still had problems with managing that fluid. And as you can see, particularly at day 40, we've got large areas of hyperdensity around where the ventricles are. And that's because of further infarction and damage and scarring to the parenchyma. So sadly, despite treatment on day 11 of illness, this was still late and still didn't stop progression of brain damage in this case. And we've done some work for looking at retrospective patients in the UK. And what we found is the day from admission to treatment of when you start TB treatment pretty well predicts how well you do. If you start early, you have mild or no level of neurological sequelae, so in the first 7 days. As it goes up, you start on 9 days or 14 days or after 15 days, then you do really badly. And if the treatment started is after 14 days of coming in, you have severe neurological sequelae, and beyond that, you've got a high rate of death. The clinical history, as you all know, is relatively non-specific. The key feature is that it's a fever or period of unwell that's longer than that for bacterial meningitis, typically lasting 2 weeks or between 1 and 3 weeks. The onset of the headache is gradual. The onset of the sort of vomiting is gradual. There may be a history of previous TB treatment, and as in the case of our example, again, there may be a contact with a TB patient, but you often have to dig to find it. Again, what we've seen from looking back in UK cases, often they are non-UK born, and they may well have recently travelled to an endemic country, or indeed somebody visited from an endemic country. And again, as all is said around the world, duration of fever is typically 2 weeks. The clinical fit picture is one of fever, altered mental status. You do have that neck stiffness, but as I said, with children, try and look for that carefully by seeing if they're just uncomfortable or moving their head rather than complaining. Focal neurological signs, particularly cranial nerve, but basically you've got to think about it. And anybody who's got these sort of features, you should be suspecting TB in anyone with meningitis. And the key feature of TB is that you should be thinking about extrapulmonary signs. So here we've got an example of someone with lymph node TB, but you should also be thinking about the chest, or maybe bone if it's really late. But sort of X-rays, as you mentioned initially in the talk, is a good idea. As we've said, lumbar puncture is key. This is I think I'm helping with an LP in Indonesia here. And as you can see, he was quite a large, chunky guy, but still it's imperative that you get help to do an LP. So the guy with the white rolled up sleeves was critical in getting a good LP here because he was able to stabilize the patient. And make an effort to practically do that, because if you can get an LP early, you're going to get that information that will help guide the diagnosis if it goes slightly more concerning later. As you know, you can get initial guides from the parameters of the LP, depending on the appearance, how many lymphocytes are in there, how much protein's in there. And as in the example, you normally have a turbid or very viscous appearance of the CSF in TB, often has a raised lymphocyte count and raised white cell count. There's usually very high protein. And as we know, the glucose ratio is typically under 50%. And as they say, there's a sort of Reb sign in India, where if you leave the CSF standing out, it tends to go have a form of Reb or cover on the top of it because of the level of protein in there. I quite like this. I don't know when this was written, but I'm impressed by the fact that we assess the color of something by gin. So I hope you still continue to do that. Sensitivity and specificity of various tests. There's no perfect test. ZN stain is very, very specific, but in different hands is very poor sensitivity. Again, culture is very specific, but depending on very much about the volume and how you've treated that fluid before you culture, it can be as low as 15%. And then various forms of culture improve it. And as we know, various PCRs move things up, but there's nothing that's perfect. More recently, we're very much moved towards molecular diagnostics, as you mentioned, the importance of getting a gene expert. And again, it's important to know that simply having a smart bit of kit isn't going to help you. You need to take care about how much volume you've got. Been shown time and time again that the more CSF you can take out, ideally aiming for 6 mils, then the better it's going to be. And work in Vietnam and others has shown that if you have a bigger concentration, or if you're able to centrifuge it down to pull down the MTB, the gene expert works better. And so, you know, there's been, and then more recently, as you know, the WHO endorsed Gene Expert Ultra, and this is a sort of advance on Gene Expert. It's got a bigger chamber so that it's able to take a larger volume of CSF, and it's regarded as being 8 times more sensitive. But again, it's about how you handle it. And the sensitivity has ranged from studies in Uganda where it's 95% sensitive, but that's against causative culture. And we already know you need a large, that's often biased by how much volume you've taken off and what you've done to that to change the positive culture. And then if you think about a clinical reference standard, it can be as poor as 47%. So the point is that both Gene Expert and now that's pushed Gene Expert Ultra are good rule-in tests, but the negative predictive value is still poor. So if you get a negative test, you should still be thinking about other stuff and saying I still need to think about TB meningitis. And I'm going to emphasize the point of CSF because it's really important, particularly for me as a pediatrician. Encouraging people to take more fluid is essential, because if you only put in a scrap of CSF, on the whole, you're going to get an indeterminate result or false negative result. If you can encourage to get up to 6 mils, particularly in adults, but then there's guidelines in the Freights' journal about sort of relative to weight, you can go up in the amount of CSF you take, then that will help. And similarly, they've shown before that if you can concentrate the CSF, again, that helps both pick up when you're looking at practically for smear and will, as I've said, will improve on molecular tests. And even in the most recent paper, one of the more recent papers in Lancet Infectious Disease, actually they showed that the Gene Expert Ultra didn't do any better than if you had a good trained staff to look at it under smear and take the effort of doing a large volume and centrifuge. So moving away from diagnostic tests because they don't always work, you need to think about clinical features. So I'm going to go through some clinical scores, and I wanted you to think about what clinical features would best discriminate initially TB from bacterial meningitis. So anything that you can suggest on that in the chat would be good. Then we'll move on to a poll.
So suggestions that more than 7 days, cranial nerve involvement, more insidious onset, negative gram stain, low glucose in CSF. Lots of people going for cranial nerve involvement here. Long prodrome, posterior fossa signs, which are interesting. History of contact.
Yeah.
Yeah, I think that's slower onset, low glucose and lymphocytic CSF.
Sounds like they're capturing good stuff. So we'll move to polls to try and see if you can pick which of those is the best.
So people need to say which is their single best answer to this.
That's right. Sorry. So very good. It looks like we're going around the high protein in the CSF, the plasma glucose ratio, and most importantly, the majority, or not the majority, but there's a common feature that length of history.
think we'll stop that poll now.
So 42% of you thought length of history, and that was the one that got the best sort of most popular answer. So,
yeah.
So of these, sorry, I should have had that before. So of these, the most popular, as you said, was length of history. And in the Thwaites clinical guideline, they found that age was, if you're older, you're more likely to be bacterial meningitis. If you had a raised peripheral white cell count, it was more likely to be bacterial meningitis. If the total white cell count was raised, it was more likely to be bacterial meningitis. And if you had a raised neutrophil count, it was more likely to be bacterial meningitis. And the single best identifying feature of TB meningitis was an insidious history or longer than 6 days. So well done all to that, particularly to that 41%. So clinical scores can help, but you really must take care about not taking it outside the intended study setting. Guy Thwaites' study was done in Vietnam, where they had lots of people coming in with the alternative diagnosis being bacterial meningitis. When we used the same data set and looked at UK patients, it was still very sensitive, so it was still able to pick up TB, but actually it was very poorly specific. So it was 10% specific. So we were calling everybody TB. And that was because there was a different range of patients, a lot more viral meningitis and a lot more alternative diagnoses. And that's the problem, that if you move away from the next biggest thing in your hospital not being bacterial meningitis, and that clinical score doesn't work. And you need to think that in the UK, there's a large range of things that can cause it. As you mentioned before, ADEM can be much more likely to be partially treated bacterial meningitis, which again would give you a more insidious onset. You've got to think about neoplastic and autoimmune. So it's a lot broader thing that comes into UK or in developing countries compared to Vietnam. We also tried to produce our own score, which is called the Child TB score, and we tested this out in KwaZulu-Natal. And again, it proved to be very useful in that environment. And again, some of the key features was an illness length greater than 7 days. We also found that if the caregiver was HIV positive, it was much more likely that the child would have TB. One of the other features we found that blood serum sodium under 132 was a good predictive count for TB. And this has been shown by other tests as well. So again, we found that in that context, again, importantly, in a place in South Africa where there is high rates of TB and bacterial meningitis, this worked. So this is for a broader population than just bacterial. Other investigations that can help beyond the clinical score is, as we've said, the chest X-ray, and then particularly head CT. And as you know, you'll get the features of hydrocephalus, or then so as you can see on the left here, big, large ventricles, or on the right, basal enhancing exodus, which are best seen if you've got contrast. And these are seen across populations, both in Vietnam and in more developing worlds such as the UK. I'd like to push the point that you nearly need to think about having the contrast. As you can see on the left, this is again a child where we haven't had the contrast added, and there is a subtle hint that you can see the basal of Willis beginning to be seen because of inflammation around there, but it really shines out if you add the contrast. So really, when you're thinking about TB meningitis, discuss with the radiographer that you get contrast in there. It may mean that an A&E staff person has to go down to help giving the contrast, but it really helps in the long term. And there's been questions about what's the best way of identifying tuberculoma, but I wouldn't worry about that necessarily, because they often come with a range of features, and you often see them in clumps that they'll have both hydrocephalus, areas of infarction or hyperdensity. There will be individual tumors or tuberculomas, and you may say basal enhancing. And this, we found that 94% of the children, had tuberculomas that presented with another intracranial or chest X-ray abnormality. So it's worth doing it, and it's worth looking for these different features to help build up the argument of TBM. Complications in the brain are common, both in adults and children, and you see that you'll often get basal meningitis, hydrocephalus, tuberculomas, or infarcts. But the big one is that basal enhancing meningitis, so remember your contrast, and hydrocephalus. So with treatment, as you all know, treatment is based on pulmonary TB. There hasn't really ever, at the start, there wasn't stuff done to sort of optimize it. As you mentioned on the case, it's really critical to gather your clinical samples first, getting that LP, try and get them to cough up some sputum. If not, in children or otherwise, try and get a gastric lavage. If you've got features externally like a swollen lymph nodes, try and get tissue of that, and it's even worth doing urine. And as you know, you need to give 2 months of intensive phase and 10 months continuation phase. Rifampicin is a great drug for sterilizing. It kills the slow and non-replicating organisms. The isoniazid kills the more rapidly replicating bacilli in the first 2 weeks. Pyrazinamide's good for getting into other areas. And ethambutol or streptomycin are added, although they're poor in CSF penetration. And this has been a sort of relatively long-standing management of treatment. More recently, people have thought about more intensive regime. And actually, the pediatricians in Tygerberg back in South Africa thought about this quite a while ago now, that sort of like, you know, if you could up the dose of rifampicin and possibly also as pyrazinamide, then you got more better treatments. And they showed that they had only 3% mortality in their intensive care in sort of intensive phase in children compared to 33% with the more standard regime. And more recently, that has been extended to adults, and particularly the group in Indonesia have done some great work in showing that high dose rifampicin reduces the overall mortality if you give, and you seem to get a strong dose response curve that the higher the dose of rifampicin, the better the outcome. Unfortunately, one of the biggest studies was done in Vietnam, and they didn't see a difference between intensified and standard care. There's been quite a lot of discussion between research groups about this. And one of the things that people thought was concerning about the study was the fact that their high dose was still relatively modest, only 15 versus 10 milligrams per kilo. And this was felt to be one of the reasons why they didn't see. But obviously, you could counter that by saying it's one of the biggest studies that's ever done with 800. More recently, the Indonesian group has combined, they've done further studies and combined them. And again, now they've got slightly bigger numbers of 148 people from 3 trials. And they've got the same message that really, if you go up in the dose that you get into the plasma, so you're going from in the black line that they've got 48 mg per liter, going up to 1,000 mg per liter, 200 mg per liter in red, you get a very pleasing improvement in outcome. So I think they're building the story, albeit not with the same numbers of the original New England Journal trial, that if you can give higher doses of rifampicin, you get a better response and possibly reduce mortality. There are other drugs, you know, nobody really knows the optimal 4th drug. Ethambutol has its problems. Streptomycin has problems with vestibular toxicity. South Africa likes ethanamide. There's been studies that have shown the fluoroquinolones have shown promise. Moxifloxacin, levofloxacin has good CSF penetration, but actually trials of treatments with levofloxacin failed to show an improved survival, and there's been more recent trials since the 2016 one that again hasn't been as pleasing as people hoped. And so still there may be value of it, particularly where you've got particular resistance, but standardly increasing, adding in the fluoroquinolones hasn't really shown the hopes that we're looking for. For TBM, it's been pretty well established that steroids are good. It helps sort of minimize the sort of like the swelling. It's particularly good for mortality in HIV negative adults and children, and it was shown to significantly reduce mortality. As we know, it might have sort of increased the numbers in disabled survivors, but then again, it's better to, one can argue it's better to have disabled survivors than dead. It's always never really been completely proven that in HIV positive people it has the same impact, but nevertheless, the guidelines suggest that you should be giving HIV and you should be giving steroids, and unless there's drug resistance, it's recommended by the WHO. There's been in the past times where there's been discussion about different regimes and timing and when you should give the dose. I'm pleased that since in 2019, NICE guidelines were updated, and now they follow the sort of Thwaites guidelines back, so that it show that you want to give dexamethasone in adults and you give it IV in a sort of steadily reducing rate from 0.4 to 0.3 back to 0.1 in grade 2 or grade 3 MRC rating of how unconscious they were. And in grade 1, it's a slightly more modest one. And then if you, like me, have children, then I personally follow the Schumann guideline if we aren't able to do the Thwaites one. Brain infarction, as we saw, is a common complication, and that steroids doesn't seem to impact on that. There's been 2 trials, both have shown that aspirin is safe, and particularly the Indian study has shown that it reduced mortality, and the high dose seems to be in the South African trial, the high dose gave better reduction of problems, albeit not changing mortality if you gave 150 as opposed to 75. So I think aspirin is good and seems to be a relatively safe treatment. There's been questions around, as you know, about starting in patients that have HIV. When do you start antiretroviral therapy? We know from pulmonary TB that early therapy increases survival because you get that increase in the immune response, and then you can get a better action with TB, against TB, sorry. In TBM, it's not so clear, and probably still we're referring back to Torek's seminal study that's in 2011, that if you give a little bit of TBM treatment first of all, probably best for 2 months, and then you come in with your antiretroviral drugs, and then you have less paradoxical reaction, and therefore you don't have the same necessarily worsening sudden sort of problems of raised intracranial pressure that we've seen with the paradox reactions before. So in summary, I'd like to say that the important things is that there's no test that's going to help tell you that you have TB. Even the molecular tests that are pushed by the WHO with Gene Expert Ultra is good for ruling in, but not for ruling out. So please take advantage of your clinical history. Think about what brain symptoms you mentioned yourselves. If you see cranial nerves injury, then think about that, but also look outside with your chest symptoms, skin symptoms, and don't be afraid of doing chest x-rays or even a CT if you have availability for the chest. To improve your diagnosis, it's really, in adults, try and get 6 mils or even more. The bigger the volume, the more chance that you have of getting enough to be able to detect MTB. And as I've shown you earlier, all the data suggests that prompt treatment, we think about it immediately for bacterial meningitis. Everybody's got that idea that if you're thinking about meningitis, bacterial meningitis, give your ceftriaxone, and you should be thinking exactly the same for TB meningitis. And again, give steroids because it helps when you've got cranial signs. Thank you.
Thank you very much, Mike. We've just got about 4 minutes for questions, so there's been an awful lot coming through. So I'm just going to answer one of them. There are quite a lot of questions about British BCG practice, and one of the people in the audience quite rightly answered that. All those details are available on the gov.uk website, immunisations. The so-called British Green Book gives details of British immunisation policy, so I'm not going to deal with that here. I'm going to focus most of the questions about therapy, Mike, but there was one about why are posterior fossa lesions of TBM more common in children than adults? First of all, do you agree with that? And if so, why?
That's right, that it has been reported that way. I have to say that in my own practice, I haven't seen that. And the fact that it seems to be a range of lesions and the tuberculomas can occur throughout. So I agree that there has been some examples of that, but in bigger studies, it hasn't necessarily been borne out.
And somebody was asking in the middle, would you not just go straight for an MR rather than a CT scan if you had a choice of both?
No, because CT is a lot easier to manage. And actually, if you've got all the hassle of getting somebody from emergency care to get them stable to going into an MR, I would always be going for that reason. So I'm more, first of all, rolling it back a bit, I'd still push that if the patient is stable enough to have an LP, so they haven't had a rapid reduction in consciousness, or you haven't got obvious features of raised intracranial pressure or herniation, then I'd be thinking about doing an LP. If I'm worried about that, I'd move on to a CT, mainly because even in the UK, out of hours is still predominantly across our DGHs is CT driven. You usually have to get a transfer referral for MRI. I'm very lucky in my centre that we can do that. but other places don't have that ability. So I'd get the CT first because it's more available. But again, I do the LP prior to that.
Thanks. And you've already indicated you would prefer to initiate empirical therapy early when in doubt. But somebody's asked, how and when do you decide to stop therapy in somebody you've started on antibacterial meningitis and anti-TB meningitis? Have you got any pearls of wisdom for us?
So that's a very, very good and very challenging question. And then for all of us that have worked both in the UK and overseas, it's a question that you come to, that you get this patient that is, you really don't know. They've had some slight improvement, or indeed they may have some slight worsening because of paradoxical reactions, or just their TB treatment hasn't kicked in. So that's why it's imperative that although I'm pushing for early treatment, to gather your samples first, that I think it is important to take that extra half an hour. What I'm telling you is that, you know, if you're going to delay from 1 day to 6 days, that's critical, or even 1 day to 4 days, that's critical. But to take time out to get the LP and to get your investigations done is about a matter of a couple of hours. So if you're organized, I'd focus on getting big volumes of CSF and getting those so that you've got your treatment in line. And then lower down the line, I would go back and redo those investigations, so that if I'm really struggling to know what's happening, if stable, I would be re-LPing to see if there's been a change in the glucose or protein to guide me. And indeed, I'd go back to getting my imaging to see if there's been any changes from there. So I wouldn't be scared to reinvestigate later on. And I would take the time, those precious hours, first of all, to get the investigations in. Unlike sort of bacterial ceftriaxone treatment, the sort of rate of sterility between giving your first dose of antibiotics and getting in is not the same for TB as it is with bacterial antibiotics. So you do have options there.
Okay, thanks, Mike. I'm going to answer one question. Is there a role for IGRA? I think the simple answer is no. And I'm going to leave it at that. So thanks, Mike. That's a very large subject, lots of questions, many of which we can't answer now. So we'll move on to the next speaker, Jim Sejvar. And just while he's getting himself ready, an appeal to Chrissy Burness, who couldn't join us to deliver a talk, but we believe is somewhere on the site. If she wishes to join in and give some commentary during or after the next case, could she please look at her phone, because I think the organisers are trying to contact her. So Tom, I'll hand over to you now.
Thanks, Nick. Yeah, so it's my great pleasure to introduce Jim Sejvar, who's based at the CDC in the USA, Centers for Disease Control. He's a fellow neurologist, also interested in the epidemiology of neurological infections, and has been a great colleague to work with over many years. Jim, over to you.
Great, thank you. Can everybody see my slides?
Yeah, if you want to just go on to presenter mode, then we'll just see the one big slide, I think.
Okay, let's see if I can do that.
Let's see.
Okay, there we go.
That's perfect, thanks.
Okay. Okay, so this is going to be one of the medium talks. And so what I'm going to do is present a case, give some questions for the breakout session, and then, you know, after that, we regroup and kind of go through people's responses and what they thought. So just to present the case, this is a 34-year-old right-handed white male who's experiencing the subacute onset of weakness and paresthesias in the upper and lower extremities. Basically 2 days prior to presentation, he developed a kind of a pins and needles sensation in his feet and the legs. And then over a period of hours, this progressed up into the arms as well. Subsequent to that, he really noticed a kind of a heaviness in his legs, found it very difficult to climb stairs. And then by the following day, he had profound weakness in the legs, and he was experiencing some difficulty with picking up objects. And essentially by day 5, there was basically complete quadriplegia, as well as the development of bilateral facial weakness. So when he presented to the emergency room, it was tachypnic with a respiratory rate of about 27, also tachycardic, but he was afebrile. Neurologic examination revealed him to be alert and oriented. He did have profound weakness in the proximal upper and lower extremities, 1 of 5 weakness. In the distal lower extremities, there was profound weakness as well, 2 of 5. And then there was weakness in the upper extremities as well. And the weakness was really very symmetric, basically affecting both sides of the body relatively equally. He was areflexic throughout. And in terms of sensory examination, it appeared to be intact to pin and light touch. He did describe, however, a sensation of hyperesthesias, particularly in the distal extremities. He did manifest profound facial diplegia, but the rest of the cranial nerve examination was normal. There was no Koenig's sign, no Brzezinski's, and routine blood work from the standpoint of a CDC and electrolytes and liver and thyroid function tests were all within normal limits. So the patient does volunteer that about 4 weeks prior to the weakness, he and his wife had traveled on holiday to Rio de Janeiro. They were there for about a week, and they reported experiencing mosquito bites as well as eating street food while in Rio. Basically, the day after returning to the UK, both he and his wife developed an acute febrile illness with a temp of about 38.2, along with severe headache and photophobia. His wife, not he, developed a mild, barely noticeable maculopapular rash, mainly on her torso. The illness was associated with moderate to severe joint pains, arthralgias, and essentially the illness basically went away after about 4 days of bed rest and just analgesics. And then 3 weeks later, this is when the onset of the limb weakness occurred. So in the emergency room, it's noticed that the patient is really quickly becoming even more tachypneic. Blood saturations are going below 93%. So as far as the questions for the breakout session, I got 4 questions. Number 1, what would be the differential diagnosis for this guy's weakness? Question number 2, what ancillary studies might be helpful in evaluating the weakness and trying to get at the differential? Question number 3, what is the most likely sort of underlying etiology of the weakness, and what is known about this etiology? And then the final question is, what are the most important steps for management and treatment of this patient, given what you feel that the differential diagnosis is?
Jim, thank you very much. I'll remind people, don't post things in the chat, please. This is a breakout session, so save your discussions to talk to your newly found friends. And I think everybody knows how the breakouts work now. So just main thing, as soon as you get in there, turn your microphone on and your video on. Don't be shy, say hello, and then somebody get the discussion going. Thanks. So Helen, I think we can probably jump to breakout now. Great, we'll give people another minute or two to come back in. Do turn your cameras off, that's good.
Tom,
yeah,
we said we'd give Jim his 10 minutes because we're a little bit...
Sure. Okay, well, Jim, let's carry on. Do you want to share your slides? We'll let people drift back in. I went to 4 or 5 of the discussion groups and there were some really good discussions going on. It's clearly a cryptic case, which is what we want.
Okay. Am I back on?
Yeah, we can see you.
Mode?
That's
okay.
it. So if you roll on.
Sure. Okay. So just to remind everybody what the questions were. The first question was what's the differential diagnosis for this man's weakness? The second question, what other kind of ancillary studies would be helpful in trying to determine the differential. Question number 3 was the most likely underlying etiology of the weakness. And then question number 4, what are the most important steps for treatment and management of the patient? So, so Tom, how?
I think we can go through. What we do is we ask the people now to post their answer into the chat to the first question, differential diagnosis, and I'll just feed some of them back to you. Okay, so we've got GBS. People like the idea of GBS secondary to something. Guillain-Barré syndrome, possibly secondary to an arbovirus because of this travel history, and people are mentioning Zika, dengue, chick, West Nile virus. Some other mentions of other infections. There's a whole range of infections triggering Guillain-Barré syndrome. Others are suggesting it might be direct attack, like an enterovirus or a flavivirus. So yeah, what did you?
Yeah. So yeah, I mean, I think those are all. I mean, it really sounds like you know, a lot of people are kind of favoring Guillain-Barré syndrome, but there are, you know, some other you know, things in the differential, which could include anterior poliomyelitis, acute transverse myelitis, paraspinal abscess, spinal cord infarct, peripheral nerve vasculitis, myasthenia gravis. But you know, it really does sound like most people were sort of favoring Guillain-Barré syndrome as the diagnosis.
I think they did. Yeah, that was by far and away the most common. So if we go on to the question 2. Oh, sorry, carry on.
Well, yeah, just to kind of, you know, reiterate to people that, you know, basically he's presenting with acute flaccid paralysis, and you know, you can see AFP within, you know, this sort of this matrix of the neuraxis, but you know, anywhere from the anterior horns to the actual peripheral nerve, and then the neuromuscular junction or the muscle. Just very quickly, you know, Guillain-Barré syndrome is a para or post-infectious peripheral nerve process thought to be due to autoimmune B or T cells to an antecedent antigenic stimulus, resulting in cross-reactive antibodies or T cells that react with peripheral nerve self proteins. Some of the most common antecedent antigenic triggers would include far and away Campylobacter jejuni, but there are others, including cytomegalovirus, hepatitis E, and more recently, Zika virus, which we'll talk about more in a second. But basically, you know, presents with acute to subacute ascending weakness, in other words, involving the proximal and then later the distal extremities. There may or may not be sensory abnormalities associated with it. The illness basically evolves over a period of days to weeks, generally with a clinical nadir within 28 days, and this is followed then by a clinical plateau and in many cases improvement. It's a relatively rare illness with an incidence of approximately 1 case per 100,000 population per year. This incidence increases with age, especially in people over the age of 65. But you know, it sounds like some other people were considering alternative diagnoses, including something that might be associated with enteroviruses, and that is you know, this anterior myelitis or acute flaccid myelitis, which is an illness that really seems to have been picking up since about 2015, with an association, strong association with enterovirus D68, which can then go on to result in an anterior myelitis involving the anterior horn cells. So in terms of question number 2, what would be, you know, the most helpful investigations to try to, you know, confirm or refute the diagnosis?
Okay, so if people want to post away, we've already had some CSF, nerve conduction studies, EMG, MRI, head, spine, and serologies in relation to the returning traveller, including HIV as a diagnostic test people want to do, stool PCR looking for enteroviruses. Anyone got anything different to say? Urine for PCR, lumbar puncture, Yeah. Okay, Jim.
That's great.
Spread.
Yeah, no, really good job. You know, one of the key diagnostic things to pursue in a suspected case of Guillain-Barré would be the cerebrospinal fluid analysis. With Guillain-Barré syndrome, it's generally going to demonstrate so-called cytoalbuminologic dissociation. In other words, a relatively normal white blood cell count, generally less than 50 cells per cubic millimeter, as well as an elevated protein. In anterior or poliomyelitis, generally there's going to be a pleocytosis plus the protein elevation. And then many of the other, kind of myoneuronal disorders, the CSF will generally be expected to be normal. People mentioned also electrodiagnostics. That's really good, and that will help in particular with Guillain-Barré syndrome to establish the actual phenotype, whether it's a acute inflammatory demyelinating polyradicular neuropathy versus acute motor axonopathy. The important thing to keep in mind with electrodiagnostics is that the studies need to be done at sort of the appropriate time or the appropriate interval, generally 10 to 14 days after the onset of weakness. If studies are done prior to that, there's sometimes not enough time for the pathologic changes to manifest, and the EMGs can be normal. In terms of neuroimaging with Guillain-Barré syndrome, sometimes you'll be able to see nerve root signal abnormality on T2 and FLAIR weighted images, and oftentimes nerve root enhancement as well. Okay, so what did people think about the potential underlying pathophysiology of the weakness, the underlying cause of the weakness? Do we have any thoughts on that?
Let's see what people have for that. So Zika has come up, Zika, chick, dengue. I think people are interested in this travel aspect as being the trigger of Guillain-Barré here. Somebody wanted to do COVID testing. It's an immune-mediated illness, says Robin. Zika seems the most likely trigger. Parry infectious molecular mimicry. So I think people are in the right territory there, yeah.
For sure, yeah. Really good. So probably given the history, the travel history to a South American country with the history of mosquito bites, Zika virus infection is a pretty good guess. It's really been strongly associated with Guillain-Barré syndrome, so Zika is an arbovirus, an arthropod-borne virus of the flavivirus genus, spread by Aedes mosquitoes. Basically a widespread distribution throughout the Caribbean, Latin America, and tropical Africa. The flavivirus family itself includes several medically important arboviruses, including dengue, West Nile virus, and Japanese encephalitis virus. Most Zika infections are self-limited, present with febrile illness, sometimes with fairly severe arthralgias and myalgias, but as far as the acute febrile illness, fairly rare sequelae along those lines. There are two medically important complications of Zika, however, and that includes post-infectious Guillain-Barré syndrome, as well as congenital defects in developing fetuses that are exposed to the Zika virus in utero. These children can develop microcephaly, as well as a number of other neuromigrational defects. The method of diagnosis for Zika, PCR is specific, but it's not that sensitive. There can be false negatives, and this can be particularly challenging in the setting of acute infection. Serology is really the most reliable way of making a diagnosis. The things to keep in mind regarding serology, however, is being aware of the serologic dynamics in infected individuals. An IgM response will last for several weeks, then being replaced by the IgG response. One of the big problems with flaviviruses in general is serologic cross-reactivity. In other words, infection with some flaviviruses can lead to an antibody response that produces cross-reactive results with other flaviviruses, such as dengue, dengue and West Nile virus. In this case, PCR is probably not going to be the most useful investigation. As people have pointed out, Guillain-Barré syndrome is a post-infectious phenomenon. And so, it would be surprising to find the virus still, presenting with a viremia. Whoops, I already. Just as far as the last question, what are sort of the management considerations here?
Maybe Jim, because time's tight, maybe
okay.
we should just keep going, because I think some people already put that in, but let's keep it moving forward, because we'll have to stop in a sec.
For sure, yeah. No, this is just outlining the treatment of Guillain-Barré syndrome. Either IVIG or plasmapheresis is thought to be equally effective. The immediate concerns for Guillain-Barré syndrome, of course, are paying attention to pulmonary function, and the early administration of IVIG or plasmapheresis is important, because the earlier the weakness can be addressed, the better the long-term outcomes. And so I'll go ahead and stop there, but people did really, really well with the questions. So thanks.
Thanks very much, Jim. So let's see what other questions people have now on that case, or this area in general. So please post any questions or comments that you have. I guess I could ask Jim, what kind of numbers of patients do you think you're seeing with these kind of problems?
You mean in the setting of Zika?
Yeah.
Yeah. In some of the investigations that we've done in Colombia and Brazil, we're looking at incidence sometimes like 20 times higher than the one case per 100,000 per year. So we've seen incidences of up to 20 patients per, 20 patients per population per year.
And in terms of, I suppose what I meant was, because we're not seeing as much Zika now as at the height of the thing. But let's see, we've got some good questions here. Jimmy, if you just stop sharing your screen, that'll make it a bit easier for people to see. A question about outcome of Zika GBS. Is it different compared to other forms of GBS?
Most of the data would suggest that Zika-associated Guillain-Barré syndrome really has the same ultimate outcomes as Guillain-Barré syndrome attributable to other antecedent infectious events.
Yeah. Someone else has said, did you ask the wife, did somebody talk to the wife about pregnancy testing, etc., because of course of the other effects of Zika on congenital disease?
Yeah, no, that's a great point. The wife was definitely counseled about the possible risk of if pregnancy was being entertained. One of the other things to keep in mind is Zika can remain dormant in testes. So one of the recommendations is for males who have been infected to not have unprotected sex if they're planning on getting pregnant.
Yeah. And then just a few questions from people in relation to treatment and whether treatment of this should be any different to treatment of other forms of GBS.
Yeah, for the most part, the treatment modalities for Zika-associated Guillain-Barré syndrome are there's no reason to alter the treatment based on Zika.
And finally, we've tried to avoid the whole meeting being about COVID because there are lots of other problems out there, of course. Somebody, Amir, says he's seen GBS post-COVID. I don't know if you've seen the data, Jim, but there's a publication just out in Brain from the UK. Are you familiar with those data showing that actually there's been less GBS this year than the previous couple of years? What are your thoughts on that?
Yeah, hopefully there's been an impact from hand washing, cleanliness issues that perhaps are exposing people to fewer other infectious triggers. And yeah, but it is reassuring to see that there doesn't appear to be any increase in incidence of GBS associated with COVID, and in fact, as the study indicated, there's actually been less GBS in some cases.
Yeah, brilliant. Okay, Jim, thanks very much for a super talk. It's time for us to stop for lunch now. We've allowed a little bit of slippage.
Okay, I'm going to welcome everybody back. I'm not sure, I think Tom's probably lost in space somewhere, but we'll get going because we need to keep to time. So for this final session this afternoon, we have a cryptic case, and then we have the Richard T. Johnson lecture, and we'll introduce Christina properly at the time. And then there'll be a quick quiz at the end. So it's a great pleasure to introduce Richard Knight, who is a senior neurologist in Edinburgh. I think went to college at roughly the same time as me. Richard, welcome with your cryptic case.
Thank you very much. So this is a case of someone who presented with dizziness and unsteadiness some time ago. And of course, neurologists see quite a lot of people with dizziness and unsteadiness. Trying to advance the slide now, sorry. Right. So these are the basic background details which I thought I'd give you first. At the time of his illness onset, he was 42, a male and right-handed, worked as a distribution manager for a dairy firm. His past medical history consisted of childhood mumps and childhood measles, of which I have very little knowledge, except that it was apparently quite bad, and he had always afterwards a very residual mild problem with the vision in his right eye. He had an appendicectomy in his childhood, and 16 years before he presented, he had a motorcycle accident of some significance. The only details that were obtainable from the notes was that he had a 48-hour post-traumatic amnesia. Family history, none of note, never smoked, little alcohol, and no relevant travel history apart from the fact that 7 years ago he had a period of work in Indonesia. So that's the background. And I thought I'd just give you the first 11 weeks that led up to when he saw a neurologist. And the beginning was he was mildly irritable, but this was really recognized more in retrospect because at the time he'd been working 7 days a week, leaving home at 6 and getting back at 9. And his wife and family thought that maybe he was just doing too much. But then he started to have episodes of what he described as dizziness. Going into these in detail, they were really not vertiginous as such, but he just became suddenly unsteady on his feet. They were brief, lasting for about 30 seconds and happening multiply. About week 6, he had one of these episodes which was bad enough for him to nearly fall. Seen at hospital, they found very little, thought he was exhausted, was told to take a week off work. During this week, he slept a lot and then felt better. Went back to work, feeling a bit off balance, but not really anything very specific. But it didn't really settle, and he saw his GP and had another week off work. By week 9, he had a stiff neck, which he complained about, although he went to some length to say this was not painful, it just felt stiff, particularly in the mornings. And his right arm felt weird, and he described this feeling as numbness. A week or so later, his right arm was a bit clumsy to use, his speech was slurred, and his wife was commenting that his walking all the time was off balance, as if he'd had a bit too much to drink. And by week 11, he saw a neurologist who described dysarthria, quite a degree, moderate degree of limb and trunk ataxia, and also diminished sensation to pinprick on the right side of the body. So just to find out what happened after that, weeks 11 to 13, just increasing imbalance. Week 13, he complained about his vision in the right eye being a bit blurred, but as I said, this had not been 100% since childhood measles. But around about that time, and now we're getting up to week 14, his wife felt that when she looked at him, his right eye was slightly turned inwards. This is not something that she'd noticed before. Getting up to week 16, the unsteadiness had got to the point whereby he was no longer standing or walking unaided. So at week 16, which is when I saw him, I was asked to see him as a second opinion in another ward. The general examination was normal. Cognitive function seemed to be normal, gave a very good history. Bedside cognitive tests were completely normal. His wife said that she thought his memory and cognitive function was entirely normal, and it seemed quite clear that his sense of humor was intact. He had a moderate to severe cerebellar dysarthria. At rest, his right eye was slightly adducted, and he had incomplete lateral gaze, especially to the left, and voluntary and command up gaze was markedly limited. There was no nystagmus, and he had a pout reflex, but not very pronounced. In the limbs, power was normal. There was possibly some mild spasticity, but it was quite difficult to tell. He had symmetrically brisk reflexes. His jaw jerk was probably brisk, but the plantars were flexor. So maybe some mild upper motor neuron features. Impairment of pinprick sensation on the right side of the trunk and the limbs, but not involving the face. And gross ataxia of limbs and trunk, unable to stand unaided. He was making 1 or 2 steps with a frame, but he was unsafe. And it was noted about this time that he had looked like a slight dystonic posturing of the right arm and the right hand at times. And occasionally 1 or 2 brief jerks had been seen in his limbs and his neck. So that's the background. And at this stage, when I saw him, the notes had included or still included a range of differential diagnoses, and in a minute I will present those for you to vote on. But in the meantime, from the chat point of view, do you want to think or suggest any particular diagnoses, what you think this might be at this stage?
So we're going to keep the discussion fairly brisk, Richard, just because of time constraints. So we've seen a few suggestions from the chat: prion disease, CJD, MS, multiple sclerosis, Borrelia, lateral medullary syndrome, Kuru, listeria, brucellosis, Chagas disease, interesting, rhombencephalitis secondary to listeria, a few people going for that. Melioidosis, Whipple's, and syphilis. So you've got a fair variety of stuff to choose from there.
Okay, so this person was in a ward in a major neurology centre, and in the notes at this time, these were the things that the clinicians looking after him had been considering. At this point, and I'm not told you any investigations or anything, what do you think is most likely? Okay, so
I think we'll stop the quiz there, thanks.
Yeah, so basically the vast majority think there's some sort of central nervous system infection, although obviously other things have been suggested here. So I will now go on and tell you some investigation results, if I can get rid of...
You hit the top right corner.
Yeah, it's obscured by something about the waiting room. Okay, right. So these are the investigations. Lots of tests were done. I've selected as many as seemed reasonable, although I can no longer see the slide, so I can't get rid of the poll for some reason.
Just there should be a cross in the top of the poll box.
Yeah, it's obscured by something else about the waiting. Oh, I have. Okay, right. Okay, right. So he had lots of blood tests done. I won't bore you all the details, but routine hematology, biochemistry, thyroid function, thyroid antibodies, nothing there. Chest X-ray and CT chest showed an apical segment left lower lobe abnormality, which was thought on the whole to suggest infection. His MRI of the brain was entirely normal, apart from a small pineal cyst. CSF protein was raised at 0.78, no cells. He had an EEG done at week 13, which showed a non-specific generalized mild excess of slow waves. And various other things were done. Antineuronal antibodies were negative, very long chain fatty acids, no abnormality, copper, ceruloplasmin, normal. And there's a whole range of things done, some of which have been mentioned, like Whipple's disease and so on, to see whether or not any of these were relevant, and all of these tests were in fact negative. So just as the progress of this person, he started with a cerebellar syndrome with an external ocular movement disorder of some sort, hemisomatosensory signs and brisk reflexes, slight dystonic posturing of the right arm, occasional jerks, but cognitively normal for the first 4 months of his illness. However, 2 weeks after I saw him, he started to be confused and had difficulty recognizing his wife. And then over the remaining week or so, he really developed a very rapid cognitive decline, becoming quite severely affected, and certainly widespread myoclonic jerks appeared. And by week 19, he was mute, bedbound with myoclonic jerks, and at week 26 had died. So that is the clinical illness. I don't know whether anybody in the text wants to say anything more about the diagnoses.
There's a fair number coming in while you've been talking, Richard.
Yep.
There's still a substantial number of people going for SSPE,
Right.
and it's really between CJD, either variant or other, or SSPE. Those are the syndromes that people are putting in.
Yeah. Okay. Well, I did mention the measles, yeah. So his EEG was repeated for over weeks 13 to 17. He had a total of 4 records, all of which were essentially non-specifically somewhat slow. Other CSF tests that were done at that time was a 1433, which was positive, and an S100B, which was raised. And because of the suspicion of prion disease, PRNP genetics was done. There were no mutations. He was codon 129MM. And for those of you who may not be clear, the PRNP gene is responsible for prion protein. And there's a common polymorphism at codon 129, whereby people can be MM, MV, or VV in the general population. So I will tell you then that an autopsy was done, and indeed he did have CJD. There was prion protein staining in the brain, particularly in the cerebellum, and the characteristic features histopathologically were those of sporadic CJD. Western blot done on the protein showed it was a type 1 prion protein, and in prion disease, the abnormal prion protein is generally characterized into 2 types, types 1 and types 2. So this was in the end a case of sporadic CJD with an MM1 subtype, although presenting at quite a young age in this man, onset of symptoms at 42, and with no cognitive impairment for the first 4 months of the illness. So I'm quite happy to take questions. I thought I'd make a few comments. Typical sporadic CJD, and of course at this point all of you may be thinking, well, this is an infectious disease course, and of course sporadic CJD is not, as is presently understood, acquired as an infectious disease, although it can be infectious and then of course be transmitted to other individuals by iatrogenic means. But typical sporadic CJD has a rapid course, median duration onset to death of 4 months. It generally presents with a global encephalopathy with a rapid cognitive decline, usually right from the onset. And the brain typically shows changes in the chordatum putamen with cortical high signal. And the EEG quite often, although not always, shows triphasic periodic discharges. This case was done before the RT quick era, And of course, these days, the CSF would be tested with RT-QuIC as well. And you would expect in a typical case of sporadic CJD for the RT-QuIC to be positive. But although that's the typical pattern, variations occur. And this is obviously a very difficult case because it is the standard difficulty of a rare form of an already rare disease. These are the changes on the right. Here you'll see the typical signal change in the chordatum putamen, which was absent in his case. And this is just to show you the green columns are the normal distributions of the codon 129 polymorphism in the general UK population. And the blue columns are the distribution in sporadic CJD, showing that MM is a risk factor for sporadic CJD. And to some degree, being MV is somehow protective. On the basis of this, people have divided sporadic CJD up into basically 6 types, although it's a bit more complicated than this, being according to whether you're MM, VV or MV and what your protein type is. And actually 70 to 75% of sporadic CJD take this typical form that I described to you. And these are generally MM1 or MV1 type of cases. So this is a very strange case of somebody who is MM1, and you would expect to see a pretty typical picture, but it really was a very atypical picture, quite a unique case. And goes to show that you may have to think quite hard about diagnosis of prion disease in some people. In relation to the comments that were made, I mean, I'm not an expert on SSPE, but my understanding is that you would expect on the whole to see abnormalities on the MRI of the brain in SSPE, but there may well be people much more expert than myself on this point. I'm open to questions or further discussion about it.
Okay, thanks very much, Richard. Just a couple of questions coming in. We had a question about how you should process and store CSF, and I think one of your colleagues, Neil Watson, replied and said freeze to -80 within 2 hours, and somebody else said put it in the Pfizer fridge. Is that your understanding?
Yeah, it's better dealt with frozen at low temperature. Yeah, like that. That's the best thing. And if people in the UK are doing it, then all they have to do is to put it in that -80 fridge, and then the CJD unit will arrange collection by courier.
So for practical purposes, we have to go and do a special LP. You can't do it on a sample that's been hanging around for a day or two in the freezer.
Well, I think the answer to that is you can. It's not entirely certain. I think that you are advised to freeze it as quickly as possible, but you may well get a positive result on a previous specimen that's not been stored ideally. Yeah.
Okay, and could I ask, just as a non-specialist, just tell us in a few words about the RT-QuIC test, which is a new one to me.
Right, okay. It stands for real-time quaking-induced conversion. And I'll very simplify it very much. You take the CSF sample and you basically put it into an apparatus with normal prion protein of some sort, the normal kind of prion protein that people make all the time, and then it's shaken. And eventually, the idea of this is that if there's abnormal prion protein in there, it will convert the normal prion protein to abnormal prion protein. And as that happens, the amount of abnormal prion protein that's present in the original sample, which would be present at a very low level, below the normal levels of laboratory detection, will increase. And you have basically a fluorescent marker that enables you to determine in real time the gradual increase of the abnormal aggregated protein. And as a result, it is a very specific test for prion disease in principle, because you're looking at the fundamental abnormality in the disease, whereas MRI 1433 and all these other tests are entirely non-specific tests, and you may see abnormalities in other conditions. I think in terms of infective forms of this, somebody with this kind of MRI picture and no abnormality on the MRI and no abnormality in the CSF, it would be a pretty unusual infective disorder, I think.
Okay, your colleagues are kindly answering some of the more difficult questions online. I'm just going to finish with one question. What's the sensitivity of 1433 for CJD?
For sporadic CJD, and I think it's very important to stress that, at the moment it's around about 70%. But for some reason, which is not very well understood, the sensitivity of 1433 for sporadic CJD in the UK has been falling.
Okay.
But it's about 70% at the moment. But
Right.
its specificity is the real problem, because of course 1433 may be released into the CSF for a whole variety of reasons. For example, after a head injury or after an epileptic seizure or after a stroke.
Okay, thanks very much. If you could just take your screen down for us, just and thank you very much indeed for a marvelous talk on something we don't see an awful lot of, I'm glad to say, anymore. So I'll hand over to Tom now to introduce the next speaker.
Thanks very much. Yes, and a clap for Richard. So our next speaker is Christina Marra. If she wants to turn on her video and start sharing her screen, that's great. This is the Richard T. Johnson lecture, which we do every year. Now, Richard Johnson was at the Department of Neurology at Hopkins, where he worked for 30 years on neurological infections of many different sorts. Everybody in the working on brain infections will have heard of him. And we've had some great speakers over the years, some of whom have joined us again on the course this year. And it's a real pleasure to introduce Christina Marra as this year's speaker. She's the professor at the Department of Neurology at the University of Washington Medical School, which is where she actually trained. And among her many roles, she's currently directing the NIH-funded clinical and translational research program on syphilis. So I'll hand over to Christina now.
Well, thank you, Tom. Can you see my slides?
We've got your slides. Yeah, that's great.
Okay. So Tom asked me to begin or to talk about my route in academics. So I wrote this out for you and I put in the number of years, but I won't tell you how old I was when I started. So I went to university and got a Bachelor of Arts in biochemistry, worked in a lab, went to graduate school, got a master's in biochemistry, worked in a lab, went to medical school, got my MD, did a medicine internship for a year, 4 years of neurology or 3 years of neurology residency and 4 years of infectious diseases fellowship. And then worked my way through the ranks of faculty to professor and now vice chair. And this makes it sound like I was very deliberate and linear, but actually this particular sign probably best describes my route. I wasn't a great planner. I depended a lot on really good advice from mentors. And I'll have to tell you that I started working on syphilis after meeting Sheila Lukehart, who's a very famous syphilis researcher, in the elevator. So I like to think it was deliberate, but I think there was a fair amount of luck involved. One of the things I've done that I want to tell you about, because I'm going to show you some of the data, is a big syphilis study, which I'm calling the University of Washington Syphilis Study. We began enrolling in 1996, enrolled through June of 2014, and then are just finishing up 5 years of additional funding to examine samples from the study. It was supported by the US government. The entry criteria for the study were really simple. The patient had syphilis and either they or their provider thought they needed a lumbar puncture to rule out neurosyphilis. And many of you will know that the criteria or the recommendations for lumbar puncture and syphilis changed throughout the course of the study, which sort of reflects how we enrolled. Participants in our study underwent a standardized history and examination, a lumbar puncture, and a blood draw. And if they were treated for neurosyphilis, they were followed for the ensuing year. This graph shows you the number of participants we enrolled over the years. And I show you this just to remark that although we had people who enrolled once and only once, we had a number of people who enrolled in the study with subsequent episodes of syphilis, and that's the light orange bars. I think the record in the study was a person who enrolled 7 times with 7 separate episodes of syphilis. Overall, we had about 1,200 syphilis episodes in about 1,000 individuals. 81% were people living with HIV, which just reflects an increased concern for neurosyphilis in people living with HIV. And we did a pretty good job of enrolling people of color. I thought I would tell you about how I met Dr. Johnson. I live in Seattle, Washington, which is here. This is a map of the Pacific Northwest. And I was invited to give a series of lectures at an HIV course in Vancouver, British Columbia, which is just across the border into Canada, early in my fellowship. It was a little bit of a challenge to get there. I flew, it's just a very short flight, but it was foggy and I was late. And when I got to the venue, it was a large lecture hall like this that was empty, save for 3 people sitting in the front row. And not only were there only 3 people there, I was the only speaker. So I gave a days full of lectures on HIV and the nervous system. And at some point during the talk, I chatted with the 3 men who were sitting in the front row, and one of them knew Dr. Johnson and had told me that he knew him. And apparently later on, after this was over, had told him what a great job I did. And Dr. Johnson invited me to give a talk at the National Neurology meeting. So it turned out to be an activity that benefited my career. But I think if a junior faculty came to me and said, should I fly to another country, lecture all day to 3 people, I would say no, that would not be a good use of your time and probably wouldn't advance your career. But in this case, it did. So I think of him very fondly, and I'm very honored to be here giving a lecture in his name. Okay, so the outline of my talk is here. We'll start with a patient example and some polling questions. We'll briefly review uncomplicated syphilis, and then we'll review complicated syphilis in more detail, including neurosyphilis, just a few words about ocular syphilis, and then some of our data on otosyphilis. We'll talk about CSF diagnostic testing, host risk factors, and we'll end with a brief discussion of screening for neurosyphilis with neurologic symptoms. So my patient is a 46-year-old man with headache and photophobia who actually enrolled in our study. He was diagnosed with HIV 5 years before he enrolled. He was off combination antiretroviral therapy for the 6 months before we saw him, with a peripheral blood CD4 of 106, quite low. On physical examination, he had ulcers in his mouth, a maculopapular rash over his torso and also involving his palms and soles, and had a healing ulcer on the dorsum of his penis. His serum rapid plasma reagent, or RPR, test titer, the test was reactive with a titer of 1 to 1024. And his serum treponema pallidum particle agglutination test, or TPPA, was reactive. So my first question for you to think about is, our patient has syphilis based on his physical examination and his test results. What do you think his syphilis stage is? And I think there's a poll.
Yeah, so in fact, let's do something different this time. I've been chatting as people have gone along. Let's go straight to the poll because I've been chatting to some people in the waiting rooms who said they'd like to just poll rather than have discussions in the chat, which can put people off. So everybody just polls for what they think the answer is here. And we'll let it roll for a little bit longer. The answers are coming in thick and fast. Place your bets now, ladies and gentlemen. Okay, so we can see... I'll just go a little bit longer and then we'll stop it and share it and you can talk us through the results, Christina. Okay, let's end the poll there and share it for everyone to see. And hopefully everyone can see that now. Can you see it, Christina?
I can.
Okay, so talk us through that.
It's like, I have the same problem as I'm using
all right.
pointer, so I can't get rid of the poll, but I'll just go like this, get rid of the pointer, get rid of the... Oh, I can't get rid of the pointer. Well, I'll just talk. So he had both a rash and an ulcer. So I think that you're all probably right. He had healing primary syphilis. He had secondary syphilis. So really he had both primary and secondary. And some argue that that's more common in people with HIV although you can certainly have seen that in the pre-antibiotic literature. Okay, so that was good. So we'll skip that. So next question, should our patient undergo a lumbar puncture? And I guess we're just going to put the poll up. And while we do that,
let's do that again. Put the poll up. We'll see how it feels. We're going to be getting feedback from everyone at the end, but we need to experiment with different approaches so they can tell us what they like.
Really controversial area, at least in the US. And the recommendations for lumbar puncture in patients with syphilis have changed over time. In the 2010 and the 2015 and the 2010 CDC guidelines, it's only recommended to do a lumbar puncture in people who have neurologic symptoms. Previous to that, it was recommended in people with HIV, and then in people with HIV who were thought to be at particular risk. So most people say yes, but some say no. So that's good. So he does have a lumbar puncture. He would have had one, I think, anyway, but because he was in the study, he did. I want to tell you that his neurologic examination is normal. His spinal fluid showed 187 white cells, almost all lymphocytes. Protein was 125 milligrams per deciliter. I think you guys use grams per liter, so 1.25. And his CSF venereal disease research laboratory test, or his VDRL test, was reactive at a titer of 1 to 32. So we're doing well. So our patient has neurosyphilis based on his CSF findings. What form of neurosyphilis do you think he has? And if you don't know about the forms, we'll show them to you on the poll. So
if we can pull the poll up, there we go.
So does he have asymptomatic meningitis? Does he have symptomatic meningitis? Or does he have meningovascular disease?
So we can see the results coming in. I don't think the audience can see them yet until we finish the poll, but we've got a good spread there. And now I think everyone can see, yeah.
So most people thought he had asymptomatic meningitis. Some thought symptomatic and some thought meningovascular. So he did have headache and photophobia. And so we'll come back to that. But I think most people would say he has symptomatic meningitis based on the fact that he had headache and photophobia. Okay, good. And then the final question, which I think is a little harder. What puts our patient at higher risk of neurosyphilis than other people with syphilis? We pop up the poll. So his serum RPR titer is high. He's not on combination antiretroviral therapy. He has a headache, all of the above, or just 1 and 2. His serum RPR titer is high and he's not on combination antiretroviral therapy. Okay, so it looks like most people thought 1 and 2, which is what I would have gone for as well. Interesting that you all didn't tumble to the fact that he has a headache. Headache is one of the things that the CDC guidelines talk about, and we'll talk more about that later in the talk. Okay, so that was good. Okay, so we're going to begin with a brief review of uncomplicated syphilis, and then we'll move on from there. So this is a flow diagram that shows you the natural history of uncomplicated syphilis that we typically teach in medical school. So primary syphilis is characterized by a painless, indurated, well-demarcated, usually single lesion at the site of inoculation called the chancre. With or without therapy, this will resolve. It will resolve faster if people are treated. If they aren't treated, they go on to develop secondary syphilis. Secondary syphilis is characterized by rash, usually can involve the entire body, but in particular involves the palms and the soles. Can be accompanied by condyloma lata, which are flat wart-like lesions in moist areas of the body, or mucus patches that can involve the tongue or the oral mucosa that look like this. With or without therapy, the manifestations of secondary syphilis will go away. They'll go away faster if you're treated. But if you're not treated, a patient will go on to develop latent syphilis, meaning they have no symptoms or signs, but they have serologic evidence of infection. In the US, we count early latent as being within the last year of infection. So I come to you in clinic and I'm serologically negative. I come back 9 months later, I'm serologically positive, but I don't have any clinical findings. I would be diagnosed with early latent syphilis. Now you'll notice I put some dotted lines in here. So our patient had primary and secondary at the same time. His primary was healing and he had obvious secondary. So he had no latent period in here, no period without disease. But some people do have a period of latency between primary and secondary. And so you could really move early latent up here. The other thing is that if the site of infection is initial infection, the site of the chancre is someplace that we can't see, for example, in the rectum or in the throat, we may not know that the patient ever had primary, and they may either just present with a positive serologic test or with secondary syphilis. Okay, so going back to our flow diagram, patients have early latent syphilis in the first year. I think it's 2 years in some parts of Europe. Late latent syphilis is defined by us as infection of more than a year duration in a person who doesn't have any clinical findings. So I come to you in clinic, I'm serologically negative. I come back 1.5 years later, I'm serologically positive. I have no findings of syphilis. You would diagnose me with late latent syphilis. Most people who have late latent syphilis never get into trouble with it. 70% have lifetime latency if they're not treated, but about 30%, at least in the pre-antibiotic era, would go on to develop tertiary manifestations. And the non-neurologic ones include gummas, which are focal, destructive, granulomatous lesions that can involve skin, bone, cartilage. This is a picture from the internet of a person who has a gumma of the nasal cartilage, and you can see that he has collapse of his nose here. The other thing you can get is cardiovascular disease, ascending aortitis, coronary vasculitis, and sometimes myocarditis. And that's still described today, although not super common. How do we diagnose syphilis? Well, we've talked about the clinical findings, which are super important in making the diagnosis. You can identify Treponema pallidum by dark field microscopy in lesion exudate from primary and sometimes from secondary syphilis, but it's really not done very much anymore. You need a special microscope and you need some special expertise. There are PCRs, RT-PCRs, and other nucleic acid amplification tests that are homegrown that people use. There aren't commercially available tests now, but there will be soon. And that can be performed on lesion exudate. There are data on using it on oral swabs and a paper from China where it was used on saliva. Can use it on blood and spinal fluid, and I'll show you our data there. And it can also be used on tissue. So it can be very useful in making a diagnosis. But we really rely on serological tests, as I've already sort of told you in my patient example. And those are non-treponemal or treponemal. So the non-treponemal are the VRL and the RPR that we've talked about already. There's another test called the TRUST. These measure IgG and IgM to cardiolipin cholesterol lecithin antigen, which is synthetic and probably doesn't have a lot to do with the organism. These tests are used to follow response to therapy. So they're titered, as I showed you, in twofold dilutions, 1 to 2, 1 to 4, 1 to 8, and so on. And they're, in terms of following the response to therapy, a 4-fold decline in titer, for example, from 1 to 32 to 1 to 8, so divide by 4, is the criteria for an adequate response. Treponemal tests include the FTA-ABS, the TPPA we've talked about, and then a variety of automated enzyme immunoassays and chemiluminescent immunoassays. These measure IgG and IgM to treponemal antigens themselves, so they actually are related to the organism. They're used to confirm reactive non-treponemal tests, and they can be used for screening. Once positive, always positive, or once reactive, always reactive. So they're a good screen for whether a person's ever had syphilis. And if you're thinking about neurosyphilis, you can't have neurosyphilis if you've never had syphilis. So a screen with a treponemal test will tell you whether your patient's at risk. Uncomplicated syphilis treatment. These are the CDC guidelines, but they're similar in other countries. So for early syphilis, primary, secondary, and early latent, a single dose of benzathine penicillin G or 2 weeks of BID doxycycline. For late latent syphilis or syphilis of unknown duration, which gets lumped into the late latent group for the purposes of treatment, it's 3 weekly doses of benzathine or a month of doxycycline. And I only point this out to you because it's important to know that these regimens don't treat neurosyphilis. So moving on to a discussion of neurosyphilis. This is a flow diagram showing you the natural history of neurosyphilis. So Treponema pallidum, subspecies pallidum, or T. pallidum, is extremely neuroinvasive. So at the time of infection or shortly thereafter, or ongoing during untreated infection, the CNS is invaded as demonstrated by being able to isolate the organism from the cerebrospinal fluid. And this can result in transient meningitis with clearance or just clearance. So unlike other bacteria that invade the CNS or the CSF, T. pallidum is cleared probably 70% of the time. And we know this from studies in the pre-antibiotic era where everybody with syphilis had a lumbar puncture, and they actually had multiple lumbar punctures that showed this phenomenon of clearance. Individuals who don't clear have persistent meningitis, or what we call asymptomatic neurosyphilis. And this is generally something we think about as occurring early, within the first few weeks to months to first few years. And these are the people who are at risk for the symptomatic forms of neurosyphilis. The early symptomatic forms, again, occurring within weeks to months to the first few years, is symptomatic meningitis and gumma. And gumma really of the CNS is different than gumma I showed you with the person with the collapsed nose. It's really just a focal area of meningitis. Meningovascular disease can occur a little later, and we'll talk more about this in just a moment. And then the late symptomatic forms of neurosyphilis, again, these people being at risk, occur years to decades later. General paresis, a dementing illness, tabes dorsalis, a spinal cord disorder. These late forms are less common in the current era, although they still do occur. And then note that I've put ocular syphilis and otosyphilis at each end of the flow diagram. They can occur early or late, and they can occur with or without other forms of neurosyphilis. So you can have ocular syphilis or otosyphilis with normal CSF, or with CSF abnormalities that you might also see with meningitis. So just to dive a little deeper into symptomatic neurosyphilis, as I've shown you already, it occurs at any syphilis stage and pretty much can affect most nervous system structures. So symptoms and signs of meningitis, typically what you'd expect to see with a quote unquote asymptomatic or aseptic meningitis, headache and stiff neck. Meningovascular syphilis is defined as stroke with meningitis. So people will present with a stroke preceded by symptoms of sort of a chronic meningitis. Dementia characterized by personality change and memory loss. And then the spinal cord disorder, sensory loss, trouble walking, bowel and bladder dysfunction. How do we diagnose symptomatic neurosyphilis? Similarly to how we diagnose uncomplicated syphilis, we look at clinical findings. Neuroimaging can be useful, and I'll walk you through these images in a moment. Serological tests, the same serological tests that we use to diagnose uncomplicated syphilis, are required to diagnose complicated syphilis or neurosyphilis. And again, you can stage people according to the usual early and late that I showed you, and then they can have neurosyphilis on top of that. CSF abnormalities, typically elevated white cells. For people who don't have HIV or people living with HIV who are on antiretroviral therapy, we typically use a cutoff of 5 to 10 white cells for diagnosing neurosyphilis. For people living with HIV who are not getting treated for their HIV, We typically use a higher cutoff simply because HIV itself can cause a mild CSF pleocytosis. Protein generally modestly elevated. In our patient, it was 1.25. CSF VDRL, specific but not sensitive, and we'll talk more about that. And then a number of treponemal tests have been examined in CSF, and the CSF FTA ABS, probably one of the best studied, sensitive but not specific. So let me take you through these images. So this is an individual who presented with secondary syphilis and a seizure. And what you're seeing on this contrast enhanced coronal image is contrast enhancement sort of dipping into the sulci over the surface of the brain, dipping into the sulci with underlying edema. And then this person who presented with facial pain has a similar finding, sort of contrast enhancement over the surface of the brain. Here it's somewhat nodular. This is very characteristic of a CNS gamma. So it's just a focal area of meningitis. This is a diffusion weighted study of a patient who's actually the patient I told you about, who went on after his meningitis to develop stroke. And this is showing small infarcts in the MCA distribution. This patient was very interesting. After he started his penicillin and his antiretrovirals were started back, he went on to develop infarcts over about a period of a week. I wanted to point this entity out to you, which is increasingly reported in the literature and doesn't fit into one of our nice boxes. So syphilitic mesial temporal lobe encephalitis in the US or encephalitis in the UK characteristically has subacute onset of cognitive and psychiatric symptoms. Seizures are really common. The same kind of CSF abnormalities we talked about, and abnormal MR shown here in an example from a patient that was presented to me at Rush University in Chicago. So this is the diffusion, and you can see this sort of hazy increased signal in the medial temporal lobe, and then the flare showing increased signal consistent with edema. And the differential really is autoimmune limbic encephalitis or HSV encephalitis. Seizures can do this as well, and I used to think this was just because so many of these patients had seizures, but there are well-described cases that don't have seizures that have these same abnormalities. So something to keep in mind in terms of presentations of neurosyphilis. I'll just mention ocular syphilis occurs at any syphilis stage, can affect most eye structures, but posterior and panuveitis is most common. And for those of us who can't remember what the uvea is, it's the iris, the ciliary body, and the choroid. Symptoms and signs include eye redness, eye pain, floaters, a very common symptom, flashing lights and vision loss. And untreated ocular syphilis can lead to permanent blindness, particularly if there's retinal detachment. We'll talk a little bit more about otosyphilis because I think it's a really difficult syndrome to understand. So we think it occurs at any syphilis stage and can affect most ear structures. Symptoms and signs in adults without congenital otosyphilis include hearing loss, tinnitus, and dizziness. And in a study of 12 people that was recently published, the audiogram showed high frequency sensory neural hearing loss most commonly. We have always been really interested in hearing loss in syphilis. And so for a period of years, we did bedside portable audiometry in patients who enrolled in our study. So here I'm going to show you the data on 394 individuals who at one of their entry visits underwent portable audiometry, which is very similar to what's done in formal audiometry, except it's not done in a soundproof booth. We excluded people who had pre-existing hearing complaints and who had missing clinical or laboratory data, and ended up with 329 individuals in our analysis. This shows you some of our our first results. So 73 of the people in our study had new hearing loss, so subjective hearing loss, 22%, but 50% of them had objective hearing loss based on their audiometry. Most commonly was high frequency loss or mixed loss, mixed low and high frequency loss. Low frequency loss alone was uncommon, And I'll tell you now that besides being uncommon, the severity of low frequency loss was pretty mild. This graph shows you the number of participants on the y-axis and then the pattern of hearing loss. So this is low frequency only, high frequency only, or both. The clear bars, clear white or clear black, are unilateral, and the stippled or striped are bilateral. And you can see that low frequency loss alone, uncommon, was largely unilateral. High frequency loss alone or combined loss was unilateral and bilateral. And then to combine a lot of analysis into a single slide, we found that detectable blood T pallidum, CSF pleocytosis, and increasing age increased the odds of hearing loss and increased the severity of hearing loss. So the first table here is looking at the adjusted odds of any hearing loss. You can see that detectable T pallidum in blood, and that was by a real-time PCR, increased the odds by threefold, increased the odds of hearing loss by threefold. CSF pleocytosis, defined as more than 10 white cells, increased the odds of hearing loss by twofold. And for every 10 years of increasing age, the odds of hearing loss increased 2.2-fold. Very similar results for adjusted odds of greater severity of hearing loss. Again, detectable T pallidum in blood, CSF pleocytosis, increasing age, all increased the odds of greater severity between 2.4 and 2.9-fold. Let's move now to a discussion of CSF diagnostic tests. The CSF VDRL is the gold standard for neurosyphilis diagnosis, but it's clearly flawed. Its sensitivity is low, while its specificity is high. And just to remind you about sensitivity and specificity, so sensitivity is the number of people who have a disease who have a positive test, and specificity is the number of people who don't have the disease who have a negative test. And the test performance is really going to depend, the test performance of any test is going to depend on how you define neurosyphilis. So what I did is I went back to our study data, and beginning in 2004, we started categorizing people according to their form of neurosyphilis in those boxes I showed you. And then I said, okay, I'm going to call asymptomatic meningitis people who have no neurologic symptoms but have at least 10 white cells in their CSF. I'm going to define ocular syphilis and otosyphilis based on symptoms and signs. And I'm going to define symptomatic meningitis as neurologic symptoms and CSF white cells above 10. So lots of studies have actually used CSF VDRL reactivity as a way of, as a gold standard to compare other tests. But if you do that, you're never going to do any better than the CSF VDRL. So here I'm using clinical definitions. Here I'm showing you the sensitivity and specificity of the CSF VDRL in our study using these clinical definitions that we just talked about. And as is shown in the literature, the specificity was high, anywhere from 89 to 92%, but the sensitivity was low, didn't even reach 50%, sort of confirming what we already knew. Many years ago, there was a study suggesting that the CSF TPHA, using a cutoff of 1 to 640, was sensitive and specific for a clinical diagnosis of neurosyphilis. And we published a paper several years ago looking at this cutoff and showing that it was specific. I went back and, using these same clinical definitions, looked at the specificity of a CSF TPPA titer at or above 1 to 640. And you can see that it's really high. It's higher than the CSF VDRL. But of course, the sensitivities are low. The sensitivity of the CSF TPPA or the CSF FTA ABS undiluted is pretty high. There was this paper that was just published, I think, from a clinic in London, looking at the proportion of patients in a clinic who were diagnosed with neurosyphilis before the CSF TPPA titer was available clinically and after. And what they found was that of the 26 people who were examined for neurosyphilis before the test was available, 42% were diagnosed with neurosyphilis. after the test was available, this number dropped significantly. And they suggested that using the CSF TPPA titer with a cutoff of at or above 1 to 640 could eliminate some of those false positive tests or false positive diagnoses. I think it's also a useful test when the CSF VDRL is non-reactive. And I've suggested to our lab that we do this. I think it won't be tremendously difficult or expensive since it's only going to be 2 wells of the plate, but we'll see. We're going to move now to host risk factors for neurosyphilis because that was one of the questions that I asked you about our patient. So this table looks at the odds of asymptomatic meningitis, as I defined it, or symptomatic meningitis, as I defined it, in our study. And what I found was that serum RPR was a powerful predictor of neurosyphilis, either symptomatic or asymptomatic. For every 2-fold increase in titer, the adjusted odds of having a neurosyphilis diagnosis went up by 30% or 1.3-fold. For asymptomatic meningitis, being in a late stage of syphilis increased the risk, but not for symptomatic meningitis. And interestingly, and I can't talk too much about this because of time, but I did tell you that people who enrolled in our study enrolled more than once. We found that previous syphilis was protective for symptomatic meningitis. Here, if you haven't had previous syphilis, you're 7.1-fold more likely to have symptomatic meningitis than a person who has had previous syphilis. And then finally, as many of you correctly identified, lack of antiretroviral use in people with HIV increases the odds of both asymptomatic meningitis and symptomatic meningitis. So in our patients, he had a high serum RPR titer, was not on antiretrovirals, both of which increased his risk compared to people who didn't have those factors. And then finally, what about screening for neurosyphilis with symptoms? So I told you that the current CDC guidelines don't recommend a lumbar puncture in syphilis unless patients have symptoms consistent with neurosyphilis. So we looked at this in our study, asking the question, how accurate is symptom screening for a neurosyphilis diagnosis? In this analysis, we included 385 people living with HIV, participants in our study living with HIV. We had 81 who were not living with HIV. They couldn't have had syphilis treatment before their lumbar puncture. So no benzathine penicillin, no oral doxycycline before they enrolled. We defined neurosyphilis fairly rigorously as a reactive CSF VDRL. I had told you that our participants underwent a structured assessment of symptoms, and here we categorized them as none, mild, moderate, or severe. And then we excluded those who had pre-existing symptoms and signs, which was really what took our numbers down. And the symptoms we looked for were headache, stiff neck, photophobia, ocular inflammation, vision or hearing loss, sensory loss, and gait incoordination. We did start asking about tinnitus in about 2004, but there just weren't enough outcomes to include it in the analysis. And again, to summarize a lot of work into a single slide, we found that the odds of a reactive CSF VDRL were not influenced by any symptom in people who did not have HIV. But among the people living with HIV in our study, at least mild photophobia, at least mild vision loss, at least moderate hearing loss, and at least mild gait incoordination all increased the odds of a reactive CSF VDRL by 2 to 3-fold. And if you looked at least moderate symptoms, moderate of these symptoms, the specificity was pretty high, 85 to 100%, although the sensitivity was low. You can certainly have a reactive CSF VDRL without symptoms. That's the definition of asymptomatic neurosyphilis. So I've told you some things about complicated syphilis, neurosyphilis, and otosyphilis that I want you to take home with you. The first is that mesial temporal lobe encephalitis or encephalitis is increasingly reported as a manifestation of neurosyphilis, doesn't fit into one of our neat categories, and you should look out for this. We've talked about otosyphilis. I showed you that screening with symptoms misses cases. that it's more common and more severe with detection of T. pallidum in blood and with CSF pleocytosis. And otosyphilis is more common in older individuals. We talked a little bit about CSF diagnostic tests. The CSF VDRL lacks sensitivity. The CSF TPPA with a 1 to 640 or greater cutoff has high specificity. We talked about host risk factors, and I pointed out the two in our patient: higher serum RPR and higher risk in untreated people living with HIV. And then we talked about symptom screening, that we've identified these 4 symptoms: photophobia, vision loss, hearing loss, and gait incoordination, and high specificity when they were at least moderately severe, but only in people with HIV. And that headache was not predictive. So those of you who said that our patient didn't require an LP because of his headache were right. That's my last slide. Just want to thank the people who've done the work. Sheila Luckhart, who has been my mentor in this work, and Drs. Giacconi and the late Centurion, who've been really instrumental in moving our work forward. And I will end there, and I would be delighted to take questions. I'll stop sharing.
Wonderful talk. Thank you so much. We've got time for a few questions. Firstly, from Richard, how many patients have been seen by psychiatrists before the diagnosis of neurosyphilis?
That is a really excellent question, and I will say that I know one. People, the psychiatrist screened with an RPR, and I had a patient who was screened and had really awful parenchymal neurosyphilis and never got better. But it's pretty uncommon.
Right,
that's for screening, but pretty uncommon.
Yeah. From Mina, thank you for the great talk. Can CSF TPHA titers be used in a similar manner to TPPA titers?
I think so. I didn't do that work, but that's how it originated, was with a TPHA. We just can't get a TPHA here.
Yeah. From Richard, would you recommend all ocular syphilis get an LP and CSF exam, even if no neurosymptoms and management unchanged? And also, should all neurosyphilis patients get hearing tests as routine?
2 great questions. So I used to say that anybody with ocular syphilis needed an LP because it gave you something to follow. I know from gossip that the CDC guidelines are going to now say you don't need an LP if you have ocular syphilis. And I think it makes sense. Only half of those people are going to have CSF abnormalities, and you're going to treat them for neurosyphilis anyway. And then the hearing test is a great question. Most of the people I saw in my study, and truly most of the people who have syphilis in our system, are seen in a public health clinic, where it's going to be pretty tough to do hearing tests, but it's actually really easy. We did it with, I don't know if you guys did this, but when I was a kid, I was screened for hearing loss with a little bedside audiometer, and that's what we used. Yeah. We did have follow-up only in about 33 patients who had audiometry, and about 50% of them improved, more improvement with the low frequency than the high frequency. So it may be useful. I just don't know if we really have the manpower to do it.
Yeah. Now, there are more questions, but because of time, I'm going to move on. But I'm hoping you, like the other speakers, will go onto the forum website, which is basically people can ask questions and you can answer them at any time that suits you. It's a discussion forum, and we'll make sure everyone has the link for that. I'd like to once again thank you for a great talk. Normally we give a gift to the speaker when they come virtually. Now I'm hoping that these have arrived.
We have the candy, which I've eaten half of, and and I got this, which I had to hide from my dogs because they
Yes, that's the Liverpool NeuroID frog. So I'm glad it made it. All right, well, we're going to move on now. Once again, many thanks for a wonderful talk. I wanted to thank the people who've helped us put all this together, really at about a month's notice. Eva Maria Hodel and Helena Heather and the Global Health Network team. I'd like to thank all the speakers and to thank you, all the attendees, who have made it a really good interactive course. And I think Nicole joining me in inviting you all to the in-person course, which we hope will happen later in the year. And if you don't get to it this year, do come and join us one other year, because it's always great fun. So thanks very much, and have a good trip home.